those of you that joined us for July, again, welcome back. For those of you that are joining us for the first time, this is welcome to our second CME series. Although we're not at Mackinac this year, we still are grateful that we're able to offer some CME. Our CME is free of cost, again, thanks to the Pro Assurance, who is sponsoring all three of our CME events. They're supporting the education and our known economic consequences, again, with shift loss, as well as elimination of CME funds for many of us. We also been supported today by Vapotherm, and they will also provide a product showcase at 12:15 p.m. today if you can join us for that as well. To claim CME, make sure that your name is visible so we can see that who's in attendance. Following the event, we will also send an email out with instructions to claim your CME. If you are calling in or on an iPad, make sure that you either send us your name or give us your phone number so we're able to kind of make sure that you're able to get that email and we have everybody tallied in. If people can also probably shut their video stream down so that way we can kind of keep the presenter basically running, and that way maybe a little bit less distraction and make sure there's no video feed issues would be great. If you have any questions or comments, please utilize the chat function. The co-directors, including myself, will be kind of keeping track of the questions and tallying them through, and that way we'll relay them. The co-directors will relay those questions to them towards the end or wherever appropriate. Also feel free to engage the other listeners by using the chat function as well. I'd like to get started here. We have Dr. Brandon Francis. He is our first speaker for the day. He'll be discussing updates in acute ischemic stroke. He is trained in internal medicine and psychiatry, followed by a neurocritical care fellowship at Northwestern University, assistant professor for stroke and neurocritical care at Michigan State University, and he's currently one of the Sparrow attendings in Lansing, Michigan. Thanks, Dr. Francis.
Thank you for that wonderful introduction, and thank you for inviting me and having me here. I am excited. I was informed earlier I might be the only non-EM physician here right now, which is fun. I can learn a lot from you guys, so please feel free to share your comments as Dr. McGowan recommended. So thanks for having me. We're going to talk a little bit about acute ischemic stroke. I'll give you a brief review over some of the concepts and then an update. And we'll focus on some of the new modality, specifically CT perfusion, as I think many of you may be encountering this CT modality, or some of you may have MR modalities for perfusion studies. Regardless, we'll go through some of the physiology and some examples, so we'll know how to use it and how to interpret it, and how to communicate with our vascular intervention colleagues when necessary. So, all right. I did serve on an advisory panel for a company, but it is unrelated to this topic, but I wanted to make sure I shared that with you. Our objectives, we'll look at some cerebral vascular territories, because I think it's really important to understand the cerebral vascular anatomy. We'll make it real simple and straightforward. We'll look at some clinical syndromes, and I think that's something you guys may want in review, and I have some slides that I won't go through that you can just keep and use as your reference later. And then we'll look at some of the time window rationale for our large vessel occlusion intervention. I think that has changed over the past couple of years, and it's a big deal in neurology, so we can talk about that. And then we'll look at some favorable CT perfusion imaging characteristics and hopefully become familiar with those. All right, so interest full disclosure, I'm on the National Committee for the Emergency Neurological Life Support certification program offered by the Neurocritical Care Society. It is essentially what ACLS is to the heart, ENLS is to the brain and spinal cord. There's 14 different modules. You can see what they are here, everything from acute ischemic stroke to traumatic spine injury, status epilepticus, and meningitis. It's all covered. And they are designed to be independent study, so you can do it all online. It is designed, you can do part of it live in person, as there may be some modules you find particularly remote for you. You may not see very much of them, and you may want to have a conversation with someone, not just look at the material. But you can do all the quizzes online and get certified, and it lasts for 2 years, very similar to what ACLS does. The benefit also is you get all of the evidence-based data to keep for yourself. So not only do you get the slides, but you get the data as well. There's videos, like I said, there's quizzes and everything to get certified. So keep that in the back of your mind. We will be offering one at Sparrow, probably in the early to mid fall. So if you're interested, please stay in touch. Okay, so the acute ischemic stroke, time is brain. Everyone gets that. Per minute of ischemia, you can lose almost 2 million neurons, 14 billion synapses. And after an average stroke, about 10 hours or so, typical 50-year-old man ages 30 years cognitively. And that is something we probably don't have a good appreciation for, because when you look at the early data on stroke evaluation and management, it's all focused on mortality. And I'm not saying that's wrong. Mortality is really important. If you're not alive, what are you doing? But once you are going to be alive, the question is, how are you living? And we're starting to see a lot more data and research go in the direction of patient-centered outcomes, meaning things that are important to patient and caregivers, such as, can you make a list, go to the store, and follow that list? It may seem like a simple task, but after a stroke, that may become really, really difficult, which means now this person who's supposedly mobile isn't really independent because they can't be trusted to go to the store on their own. And some may argue, I know my wife would, I should not be allowed to go to the store on my own either, because I always come back with something inappropriate. So let's talk about the anatomy. And this is the way I teach myself how to think through the anatomy. And while there's a lot of details, there's only a few areas you have to actually know. And I'm going to talk about it and then we'll show it. Okay. So there are 4 vessels that go to the head. 2 in front, 2 in rear. The 2 in front are called the internal carotids. How do I know they go inside? Because they're called the internal carotids. What do? When they go inside, they bifurcate to form the ACAs and MCAs. That's it. That's your anterior circulation. Your posterior circulation, the 2 vessels that go up are the vertebrals. They join to form the basilar. The basilar bifurcates to form the PCAs. That's it. That's your posterior circulation. We know the PCAs join the anterior circulation via the PCOMs. But essentially, if you can follow the 4 vessels up, and you can follow the internal carotids where they bifurcate to the ACAs and MCAs, and you can follow the verts where they join from the basilar and they bifurcate to form the PCAs, you can identify all the major vessels that are typically addressed during neurointervention. Yes, I understand there are distal M2 occlusions and proximal M3 occlusions that some interventions will go after in certain circumstances. I get it. That's true. But majority of the cases we're talking about are really going to be your major anterior vessels. So your ICAs, your MCA and ACA territory, A1, M1. And if you're going posterior, you're really looking at the basilar and occasionally an M or a P1 segment, maybe P2. But if you can find those, you're done. Let's take a quick look at it. Here it is. It's your classic picture. Your anterior circulation comes up and bifurcates to your MCAs and ACAs. Your posterior circulation, your verts come up to form the basilar, and those are your PCAs right here. That's it. There's a lot of other vessels we can talk about and get in the weeds on, but really, this is where the data is. The data is all anterior circulation, and you've got life-sustaining therapy in the posterior circulation. Okay, so now that we understand some basic anatomical concepts from a cerebrovascular perspective, let's take a step back. Based on the image, what is the likely anatomic vascular deficit? So what region is it in? The neurological deficit we can get to, and we'll go through those in a second. All right, so these are going to be just sort of self-study. I'll give you a second to look at the image, and then we'll go over the answer. Okay, here we go. This is nice. So we see 2 CT scans here. They're the same person, different levels. These are axial views, and they're non-contrast. All right, if you look at the image on your left, follow my cursor here, the left image, you'll see on the left side of the brain, which is this side here, you see 2 hypodense areas here. And on the image on the right, you see another hypodense image here, a little higher up. What vascular territory is that in? Good. So this might be an area of what we call watershed infarct, right? Watershed infarct. So it's in between the ACA and MCA territories. And in the back, it's between the PCA and MCA territories. Watershed means where you have two vascular territories, they may join by small amounts of capillaries or collaterals. Right? Those collaterals are the first to fail in low flow states. Okay, moving on. What territory is this? This is also an axial, non-contrast CT of the head. And if we look, we see a hypodense region in this region right here. If you follow my cursor. This is a posterior cerebral artery stroke, early signs, evidenced by hypodensity. And as we see, there is a paucity of sulci here in this posterior area, suggesting there's early signs of cerebral edema. And you see loss of gray-white matter differentiation here as well. Okay, very good. That was a PCA territory stroke. All right, moving on. Same type of scan, axial non-contrast CT of the head. And again, we'll see on this left side an area of hypodensity here and here. This is suggestive of your MCA infarct, middle cerebral artery. There are some areas of hyperdensity here and here and here. And the question is, while these hyperdensities are considered normal variants, what about this one? And there's a little bit of hyperdensity mixed through here. And so the question is, I wonder if there's some early hemorrhagic conversion occurring. Moving on. All right, look at these two images. Again, axial non-contrast CTs of the head. These aren't the best quality images, I grant you that. But if you look, again here, follow my cursor on the image on the left, you'll see the left side of the brain here has a hypodense area, which is in the ACA territory. And we follow it over here, you can see it more clearly demarcated here. So we've gone through and seen some ACA, MCA, PCA, and even watershed areas of infarction and what they look like on plain non-contrast CTs of the head. If you remember, the ACA territory has contralateral leg weakness, some sensory loss. And you can have apraxia and incontinence as well. Proximal MCA, this is where you get your contralateral hemiplegia and hemisensory. You can get a visual field defect. If you're dominant hemisphere, you get aphasia. If you're non-dominant, you get neglect. Now, neglect, if you remember, is not recognizing half of your world. So they won't even know it's there. So if you stand on their left side, they won't acknowledge you. You can even hold their hand in front of their head and ask them, whose hand is this? And they'll tell you it's someone else's hand. They'll say it's your hand or their spouse's hand if they're sitting next to them, but it won't be theirs because they won't feel it or recognize it as being part of their body. That's different from extinction. Extinction is when you can touch that part of the body, they recognize it, acknowledge it, and say, yes, I feel it. But if you simultaneously touch the opposite side of the body, so you touch both hands at the same time, they will extinguish that recognition of you touching the left side. That's different than neglect. Okay. And here are vascular territories. I'm not going to go through this, but I thought it was a good review slide in case you wanted to use this as reference at a later point in time. Okay, I think, Jeff, if you want to pause and if anyone has any questions or want to go over anything, now might be a good time to start with that review.
If there's any questions, anybody, you guys can also put it through the chat as well. I don't have anything on there currently yet.
Okay. Then if that's the case, we'll keep moving. We'll start with some basic stroke mimics. I think as everyone here is familiar with, a lot of things can mimic stroke, and this becomes a challenge. I'll tell you from my personal experience, the things that we see as the most common for masquerading as stroke are your toxic metabolic encephalopathies. These people can have focal deficits, which can be really confusing. So can your migraineurs. They'll come in of a history of migraine, and they'll never have had neurologic symptoms such as weakness or sensory changes or speech changes with it, but now they do. And they don't have a headache, right? And so it's the new type of migraine for them, but they have no way of knowing that, so they come in. And we have to evaluate them and treat them as if they have a stroke, which means they'll get the full imaging and all of the proper processes, all the workup and everything. And if it's negative, we then tell them, congratulations, you have a new type of migraine. Patients are sometimes quite resistant to this. They're glad they don't have a stroke, but they're resistant, saying, no, 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 I've had migraines for 30 years. I know what they're like, and this is not a migraine for me. And we have to educate them that, yes, that migraines can change over time. And you may only have it once or twice, but this can be a new migraine for you. And you don't have to have a headache with it. And that's really hard for some migraineurs to wrap their head around, because they're very used to having disabling headaches, for example, that take them out for a day or two, or headaches that they can abort taking some medication, but they know the process and what's going to happen, and this is very different for them. Another one I see quite a bit are your non-physiologic or conversion spectrum disorders. They can come in and present as headache. And it's not just conversion, but anything from schizophrenia to depression can present this way. Yes, they can have focal deficits. And it doesn't seem as if they understand the details of it. It just feels very real to them, and they're not faking it. So the people that are faking or malignant, that's a separate issue. I'm talking about people that come in with symptoms they believe are real. They feel real, and they will engage you as if they're real. And we still do the full workup on them as well. Okay, so acute management of stroke. We're going to go through some specific areas of interest, focusing on the time window that's going to help us with CT perfusion. So, general principles of management. You guys are ED docs. You know this better than I do. You have permissive hypertension. You avoid hypoglycemia. You treat fever. Avoid hypotonic solutions. Remember that all patients with brain injury, the brain is like every other organ. If you hit your arm, it swells. It's fine though, because you have skin that stretches. The brain, when it gets injured, it also swells. But because it's encased by the skull, it has nowhere to go. So when it swells, it can cause additional damage and even mortality. So we recommend avoiding hypotonic solutions, which includes LR. Yes, LR is a hypotonic solution for the neurocritical care patient. We can go through that in detail later if you're interested. I have no problem doing that. We have a lot of other stuff to talk about. So if you want that question answered, put it in the comments and we'll get to it later. And then treat seizures only if they occur. There are some areas where seizure prophylaxis has been shown to be a reasonable option. Acute ischemic stroke is not one of them. So we don't typically recommend seizure prophylaxis in this patient population. However, if you see a seizure, we recommend treating a seizure. It's sort of like running a CTA in New York City. See something, say something. So if you see a seizure, by all means, go after it. And now, connecting with our neurosurge colleagues, there is some opportunity for individual management here. But for patients with cerebellar infarction, because the posterior fossa is so tightly packed in such a small area with such close proximity to the brainstem, we recommend neurosurgical consultation for many patients with cerebellar ischemia or hemorrhage, because the area for swelling the opportunity is so great and the margin for error is so small. We also will get in contact if there's hydrocephalus or what we call a malignant or massive hemispheric infarction. So the more common example is malignant MCA syndromes. That's where you cover 2/3 or more of the MCA territory. And it isn't always apparent on initial presentation. In fact, we've had several patients come to the hospital who are interactive, but have a large MCA stroke. And they get intubated for airway protection or for the workup, And then they go to the ICU, and the ICU team says, hey, they look great, let's extubate them. And I have to pump the brakes, say, hold on, let's reevaluate this. They are day 1 or day 0 stroke. When do patients tend to swell post-ischemic stroke? Right. The peak swelling period is between days 3 and 5. So if you're going to extubate a patient on day 1 or day 0 after a large MCA infarction, you can be putting that person in harm's way because they're likely to swell and worsen their mental status and worsen their ability to protect their airway. So remember that you need 2 reasons to avoid the tube for neurocritical care patients. 2 reasons. 1, you have to breathe on your own. Most of them can do that because their lungs typically aren't affected as a primary problem for them. So 2 things. 1, breathe on your own. The second thing, you have to look good doing it. I know it sounds silly, breathe on your own, look good doing it, but neurocritical care patients have trouble with the second one. It's not typically a gas exchange problem. It's typically they don't look good breathing, meaning they're tachypnic or they're gurgling. That's very common. They gurgle because they can't manage their secretions, but they're strong. They can cough, but they can't coordinate these efforts because they're neurologically injured. So keep that in mind. Breathe on your own, look good doing it. I don't spend a lot of time going through lab parameters with neurocritical care patients because the labs will look just fine. Okay. So typical stroke code, we look at time of onset or last known normal. This can be complicated to get details on. Many times people think that their last known normal was when they first noticed the symptoms when they woke up in the morning. That's not really what we're talking about. Obviously, you guys do this every day. You know, getting them to go back to when they were last known to be completely at baseline, and that might often be the night before they went to bed. The NIH score or exam, that's really helpful. My personal approach to this, because there's a lot of information in stroke and vascular neurology, is to simplify things. And I see the NIH really in 3 categories. I see people with NIHs below 6, so 5 and below. And I see people 6 to 26, and then I see people 26 and higher. Why do I see it that way? Because for me, in my observations, I've noticed people 26 and higher oftentimes have a very difficult time with their outcomes. People 5 and below tend to have pretty good outcomes. And people in the middle, those people I'm really targeting for the interventional therapy we're going to talk about, because they're the ones that have an opportunity to have a much better outcome if we can intervene on them. Now, I want to be very transparent. I get that if we talk at all comers with stroke, all comers, we're only talking about a very, very small percentage of people we can intervene on. And the real benefit is controlling, for the majority of people, is minimizing the risk of stroke in the first place. Things like blood pressure control, which is linearly related to stroke risk. Remember that. Even if your blood pressure is normal, if your blood pressure is normal and you can drop your blood pressure, you'll be at decreased risk for stroke. Obviously, there's a lower limit to that because you don't want people syncopizing and then coming in with all these head traumas. Still, I get to see you, so does ortho and trauma, but that's not the goal. The goal is to not be seen at all. So yes, it's a linear relationship. So if you can lower your blood pressure, you can decrease your risk of stroke. If you don't smoke, you can decrease your risk of stroke. So these are very important things, and if we can address them, we can cover more people. But for those that do come, and if they do meet criteria, we're going to talk about the next steps. So yes, get some relevant history, labs that are necessary, and CT findings, because that'll help you determine the next steps. Here's your NIH stroke scale. I think we're all familiar with this. Personally, I love the picture because I think the little girl was the mastermind behind the whole thing. The little girl turned the faucet on to distract mom. Now, mom is busy now at the faucet. She got her accomplice to go up on a stool, and clearly she's laughing, does not care that he's falling. She just wants the cookies. So she's the mastermind in my mind. All right. Here is one example of a protocol that's been used. This was the British Medical Journal. The references there. You don't like it, go after them. I get it. There's a lot of different ones out there. I do not know what your institution's using, but they're probably using something similar. And we're going to focus on this area right here in the blue circle. We're going to look at the patients that come in greater than 5.5 hours, but less than 24. This is an area of interest, and this is a new way of addressing these patients, which is different than it was 10 years ago, 5 years ago. It's a big deal. Okay. So CT perfusion. I'm going to stop right here. Were there any questions or comments up until this point? Because now we're going to get in the weeds.
As of right now, I don't see any new updated ones now.
Okay, so either everyone's asleep or everyone gets what I've talked about so far. That's fair. Okay, here we go. CT perfusion. We need to agree upon there are two groups of neurons after an acute ischemic stroke. One, dead neurons. Those neurons are gone. You can't fix them. You can't get them back. And then two, neurons that are at risk of dying. That's the population we're interested in. Dead neurons will be your core ischemic tissue. These are the ones that are represented by DWI on your MRI. But I don't know about you, but getting stat MRIs from the ED can be challenging sometimes. Not because our ED physicians don't want to do it, but logistically it's complicated. There's a lot of things to get organized to get an MRI acutely. But there are some facilities that have MRIs dedicated for the ED. And they have a special process of getting the checklist worked out and the safety parameters taken care of to get stat MRIs for people that are not able to respond. And in those facilities, they engage with people only with DWI positivity. That being said, they still have to engage with MR perfusion, help guide therapy for people outside, from 5.5 hours onward. Okay. So CT perfusion can demonstrate cerebral blood flow, volume, and then time-related variables. We'll go through those. CBV can be correlated to your diffusion. MTT, or mean transit time, can assist in identifying tissue at risk. And we'll look at those in just a second. And the idea is that we're looking for neurons at risk of dying, or penumbra, your tissue at risk, and that can be represented by a perfusion-diffusion mismatch. So I think we're going to draw it now. So forgive me, I'm going to take a second to get this next piece set up for you so you can see it. Okay. All right. Okay. Can you guys, hopefully everyone can see this? All right. Okay, so you can see what I'm doing now. We're going to now draw a little bit of this live. Okay, let me get my pen ready. All right, if you look at this first area right here, right where the green marker is, we're going to have this box, and we're going to call this box our voxel of brain tissue, okay? And here, this red dot is a blood cell going into this voxel. And that blood cell will go into the voxel with a certain flow. We call that cerebral blood flow, okay? When it goes into that voxel of tissue, as we come over here to this arrow, you're going to see it's going to fill that voxel of tissue with a certain volume. We're going to call that cerebral blood volume. I know it sounds simplistic, but these are the bases and principles behind CT perfusion. And then over here, you're going to see it took a certain amount of time to get that amount of blood to fill that voxel. And so there's different time parameters depending on your software and hardware at your institution. You can either look at the amount of time it took to peak or time to peak. That's one time parameter you can use. Another one is say, well, how much time did it take to go out of that brain tissue? And you can say that's time to drain. Another time parameter is you can say, what was the mean transit time in that it took for that blood cell to get through that tissue? Mean transit time. So that's what we're going to spend our time talking about. So we have to remember CT perfusion uses contrast. And what it does is it looks at where the contrast starts and where it ends and figures out the flow, volume, and time. What that means is it has to pick the correct location for the start of the blood flow. So you'll see in your cerebral perfusion maps, if you actually go through the imaging, you'll have a picture of a skull, and you'll have the vascular tree here, and you'll see an area where it'll designate as an in, so where the blood is supposed to start from. And then you'll have another picture of a skull, and you'll have your venous structure represented here. You have your sinuses going here and here, and it'll pick some area here for where the blood's ending. If it's not picking an artery and a vein as your start and end points, you may have difficulty interpreting the study. Does that make sense? Another thing to look out for is because you're giving contrast, people often ask, can you get a CT perfusion after getting a CTA? The answer is yes. Here's why. So when the CT perfusion, it looks at where the contrast starts and where it ends, and it looks for differences in contrast. So if you already have contrast in there, it'll consider at time 0, this amount of contrast started at point A. When you get the bolus of contrast for your perfusion study, the contrast will be here at a much higher level. Even if you already have contrast in there, there is a delta there. There is a difference. The machine can recognize that. So it can still see the difference between contrast and adding another bolus of contrast versus no contrast and adding a bolus of contrast. The difference is the larger the delta, the more sensitive the test. So yes, if you give a CTA, you can use a CTP after, but because the delta is lower, your sensitivity will be lower, and you may have a difficult test to interpret, but you can do it and it might be useful. So don't decline for using a CT perfusion study just because they've had a CTA already. Optimally, the idea is to give a CT perfusion first and then do the CTA, because the vessels will already have contrast in them and the computer can see them. Good. All right, now that we have those two things out of the way, let's go to this last example here, which is by this arrow. All right, so we have our voxel of tissue, we have our flow of blood going in, and we have, it took a certain amount of volume of tissue to get up. What we have to remember is that dead brain tissue doesn't fill with blood very well. Dead brain tissue has less blood in it. All right, so if you have a voxel of brain tissue by itself that's dead, you're going to get much less blood. You have an entire area here that has no blood in it. We're going to use that to our advantage. So in this, getting back to this example here, blood goes in, the normal parts fill normally, gets to this voxel area here where it doesn't fill very well at all. Hence those little dotted lines not filling. But outside the voxel, it fills fine. So you get two different areas here within the same voxel of space. And this is where you have your perfusion-diffusion mismatch. Okay, let's take a look at this. If we look down here at the bottom, we remember that our CBV, or volume, can be analogous to our core, which is analogous to our DWI. I say analogous because it's not the same. I'm not actually showing you diffusion restriction. What we're showing you is reduced volume. Now, volume and diffusion restriction are correlated because, like we said, dead brain doesn't fill with blood very well. We do know that mean transit time is super important. So any of these time parameters can be substituted for mean transit time. We'll talk about mean transit time because that's what I'm personally more familiar with, and that's what a lot of the studies are based off of. So we know that if it takes a long time to fill brain tissue, that brain tissue may still be alive, but it took a long time to get there. That tissue is at risk of dying. If it continues to take a long time, that tissue will die. Make sense? So your mean transit time has both core and penumbra within that measurement. So your mismatch is going to be penumbra that's going to be separated from your core, and that's what we're targeting. Okay. So the question you're going to ask me next is, what does normal look like? So if we're looking at cerebral blood flow, it's typically 60 cc's per 100 grams of brain tissue in a minute. That's your typical blood flow. Your typical blood volume is about 4 cc's per 100 grams of tissue. Mean transit time is typically around 4 seconds. So it takes 4 seconds to go in and come out. If it's taking longer, you got problems. All right, so abnormal, what do you measure as abnormal? And if you look in the literature, there's some discussion about this. You can use cerebral blood flow, because we know if you're not getting blood flow, you have a problem. You probably have dead brain tissue. But remember, flow equals volume over time. So you can have preserved flow even if you've got abnormal variables of either volume or time, right? So flow isn't the best at determining what's abnormal. And you can see here, area under the curve yields 85% accuracy here, right? So if you have less than 30 cc's per 100 grams of tissue in a minute, that's considered abnormal and it's likely dead tissue. But it's much lower sensitivity and specificity than your cerebral blood volume, because if that's going down, there's no way to compensate for low blood volume, and you end up with a much more sensitive test. So if blood volume is less than 2, then you end up with ischemia, or infarction, excuse me. Mean transit time is a little bit funny. We know that 4 is normal. Anything greater than 4 is bad. And so what you'll see when looking at your perfusion maps is you'll see it have a color guard next to it, and I'll have a chart. And these charts will be filled with different colors, say red, blue, green, yellow, and it'll shade in the CT map for you. And you can see, so this will be 10 seconds, this will be 0 seconds, and 4 will be in here. And this is typically what you're looking for. If you start seeing colors up in this spectrum, you know you're getting abnormal. Make sense? Okay. Let's go to the next set of information and see what we get. Okay. So now let's come to the nitty gritty. We're going to have 2 skulls here drawn for you. The first one's going to look at cerebral blood volume. The second one will look at mean transit time. All right. So in this example here with cerebral blood volume, you have your head. You have a small area here of cerebral blood volume loss, and that is going to be about 5 mLs of tissue. We're going to compare that to our mean transit time map. Your mean transit time has a fairly large area, as you can see here, of dysfunction. This accounts for about 50 mLs of tissue. So let's take a step back for 1 second. We all talk about the NIH stroke scale. Why do we care so much? This is why. All that work before, all the data before, was all about this. It's all about your mean transit time compared to your CBV. When you look at a patient, you're going to get your exam based on all the dysfunctional tissue. So if you have a large mean transit time, that person has a high NIH. Maybe their NIH might be as high as 20, maybe higher, right? So bad neuro exam is telling you there's a lot of tissue that's dysfunctional. You can't tell on your neuro exam whether it's dead tissue, like over here in your CBV, or tissue at risk, like over here in your mean transit time. But you can tell it's abnormal. This is the power of CT perfusion. You can distinguish these 2 variables. So if you now take your mismatch volume and you subtract and you get the difference, we're talking 45 cc's of tissue at risk that you can fix. You have the opportunity to fix that tissue. Or you can look at it by ratio, which is 10, right? So if you take the same patient and you do intervention, this is thrombectomy, what you're left with, you remain this 5 cc's of tissue that is dead. Because it's already dead, you can't fix it. But look at your mean transit time. It's normal now because you restored blood flow. So all this tissue up here that was abnormal, but surviving, barely hanging on, was hanging on by collaterals, was hanging on by some other means of getting blood flow. But it can't survive that way. It goes into a dormant state trying to survive. So we did thrombectomy, and we ended up with normal blood flow. Your NIH went from 20 to 2. That's a big deal. Therein lies the power of thrombectomy. And this is how we predict who is likely to benefit from it. So, but there are some key things to think about. You have to be very careful. Even if you have a mismatch, you can't use a mismatch if you have a large cerebral blood volume core. Why might that be? Yes. Let's take a second to think about that. We know that dead brain cells tend to become very, very friable. If they're friable, they're likely to bleed. So if you reperfuse a vast area of infarcted tissue, you increase your risk of a catastrophic bleed occurring. So we don't like to do that. Are there exceptions to this? Of course there are. These are just some basic principles by which we use to guide our approach. There are exceptions to this rule, but by and large, be very cautious if you see greater than 70 cc's for 100 grams of tissue in your cerebral blood volume. All right, so if you see more than 70, be very cautious considering intervention. Make sense? Another way of looking at this, looking at the ratio. If your ratio is less than 1.8, you may not want to intervene. Now, there are some caveats to this. Some caveats would include, let me see. All right, some caveats that might include this would be areas like, let's get a different color so maybe it's easier to see. Okay, so you have to remember that when you have your two vessels come up in the front and they bifurcate from your ACAs and MCAs, these are large vessels, okay? And so they cover large areas of tissue. That's your MCA territory, right? And your ACA territory, rather large areas of tissue. Remember your posterior circulation, your vertical at the front of the basilar, and that forms your PCAs. This whole region is fairly small, and your basilar has a bunch of perforators off of it, right? They're very small areas. So if you're going for posterior circulation, you may see very small hits that may give you a very bad exam because you're hitting the brainstem. That is your communication in the outside world. Even a small ditzel there can be a big deal from a neurologic perspective. So you may have a massive NIH, but a very small stroke, but it's in a terrible location. Your perfusion study may not pick it up very well. So be cautious using CT perfusions in posterior circulation strokes. Okay. Additionally, we talked about large artery, large territories, right? But then you have these little tiny areas that are within the anterior circulation territory that get hit. And they are called lacunes. And they cause lacunar syndromes. Be cautious in interpreting CT perfusion studies in lacunar syndromes. Okay, why? Because we're talking about a fairly small amount of tissue. So a fairly small vessel got blocked. You may not pick it up on a CT perfusion study. Okay, so these aren't the end all be all of everything. Okay. Another one I want to watch out for are anything that causes alterations in flow, right? So remember, we have our internal carotids coming up and they bifurcate from your ACAs and MCAs. But if this is stenotic, if your ICA has abnormal flow, markedly abnormal flow, the machine will pick up a different side to side, but you may have difficulty interpreting which side's normal. Okay, does that make sense? All right, good deal. So let's back up here and go through some basic principles so we can get to know what we're talking about. Cerebral blood volume. Here's an example where you got this defect here versus this defect here. That defect is matched, which means you don't want to intervene on this patient. No, no. This one, you have your blood volume is normal. There's no dead tissue. Yet here in the ratio, you've got a lot of tissue at risk. Yes, you want to go after this one. This one here, yes, you have a mismatch, but you have a very large area of tissue. You probably don't want to go into that one there. All right. Listen, guys, I'm going to stop right here. We've gone through the material on CT perfusion study. The only thing we didn't get to go through is the actual trials and data supporting this approach. The data is pretty good. We can go through that in detail if there's time. So I'll stop here and stop sharing my screen and see what questions I answer for you guys.
So Dr. Francis, one of the questions we had, which is every ER doctor's favorite discussion, is always the wake up strokes.
Mm-hmm.
Do you want to go through some of your thought process? And I know like at Sparrow, which you're at, we do CT perfusions and things like that. Do you want to kind of go through some of the discussions for wake up strokes? Because that's a very common one that we deal with.
Yeah, exactly right. So this is wake up stroke, what we're talking about right here. These people have had some sort of symptomatology between 5.5 hours and 24 hours. As long as they were normal within 24 hours, this is the population you want to consider for CT perfusion study. Here's the catch though, they have to have an abnormal exam. So they have an NIH 6 or greater, and they've been found to have the last known normal between 5.5 and 24 hours. CT perfuse these people. If you don't, you have to have a good reason. This CT perfusion study will help you stratify the patient population, because with your perfusion, you get angiography with it. It's like peanut butter and jelly. It just sort of comes with it. And that'll tell you if you have a large vessel occlusion that's able to be intervened upon. And then your CT perfusion study will tell you if you should intervene upon it. So these are your wake-up stroke patients. It takes a lot of the guesswork out now, guys. Between 5.5 and 24 hours, with NIH greater than 6, by all means, CT perfuse these people. If you don't have one, get one. Send them to a center where they can get CT perfusion. It can change management dramatically.
Dr. Francis, Therese Mead here with a question. Our hospital is just getting an AI service where, because there's a little bit of delay in getting our CTAs read, they're going to have us using an AI service where we'll get a text on a cell phone with what the AI says is going on the CTA, LVO, not LVO. What are your thoughts about these AI programs? Yes,
I think there's a lot of opportunity and a lot of promise in these AI programs. I think the gold standard will still be a neuroradiologist and or neurointerventionalist or a neuro person who does this for a living reading it. But it's not just having an LVO. It's also having favorable perfusion characteristics for people that are 5.5 to 24 hours. If you're before 5.5 hours, you don't need a perfusion study, okay? Because the physiology suggests those people are at lower risk of bleeding because the stroke has not been going on that long. So the AI can help you in those situations, but outside of 5.5 hours, you're still going to need a perfusion study and someone to interpret and put that together for you. I'm not sure that answers your question, though.
No, it certainly does. Are there any other questions coming from the chat box? I haven't seen any yet, but this is a great time to ask.
So I'll leave you guys with one more thought as you think about this. When we think about interventions in medicine, we think about medications or procedures. We think about number needed to treat. If you look at the data on thrombectomy in this patient population, when you take all comers that get thrombectomy, the number needed to treat is 2. I'll say that again. The number needed to treat, 2. Tell me how often you see that in your practice. I'll wait. Right, it's really rare to have a number needed to treat so small. That's why we're spending our time going over this particular subset of patients, because if you qualify, it can be a dramatic response for you. Other question I can help you with?
We have one question. I know we still have a couple, it's okay if we go a couple more minutes, but they said that, do you have any images that you had for like examples, like on CTs or kind of what the perfusions might look like for people? Because I think a decent amount of people, I think, have that CT perfusion available, but I'm sure there are plenty that do not.
Yes, I do. I'll pull that up for you. And turn this big device off, otherwise it'll screw up the ability for you guys to see the screen. Okay. Can you guys see this now?
Yes.
All right. Here is what a CT perfusion study looks like, guys. Here is your CT, your cerebral blood volume map on the left, the pink one, and your green one is your, in this case, we're using Tmax, which is another variable that's also well supported in the literature. It all depends on your software and the hardware that you have. But you can see very clearly here, you see there's a small area of volume, meaning a small area of tissue that has low blood volume, which means it's dead. And then on the right side here, you see the green area shows a large area of tissue that's at risk. It has low flow. They have low flow, so they're dysfunctional. So you have a bad exam. I guarantee you this person has what looks like the entire MCA territory is knocked out, right? So it's a terrible exam. But look at this mismatch. You have 177 cc's of tissue at risk, but only 44 cc's of that tissue is actually dead, which means your mismatch volume is huge. Your mismatch ratio is huge. It's greater than 1.8. This is the person you want to intervene on. Does that make sense? And here's what it looks like when you intervene on them. You go through and you see the clot right here. There's no flow behind that arrow. Then suddenly there's flow, which means this person gets a significant improvement in their outcome. There's a great potential here. Jeff, how am I on time?
Probably about another minute or so. Is there any other last minute questions or anything? Let's see here. I think that about does it. Anything else, Dr. Francis, you want to cover in the last minute or so?
Well, we can look at the Dawn trial, which was helpful in terms of leading the way for thrombectomy. And that really looked at 200, just over 200 patients, last known normal in the time period we're talking about, so greater than 5.5 to 24 hours. 100 were in thrombectomy, 99 in standard group. And here's the kicker. Functional independence at 90 days was dramatically different, so they stopped the trial early. When you look at meta-analyses on this, don't take my word for it. Look at it yourself. Look at the meta-analysis on thrombectomy in acute ischemic stroke. It is not subtle. So I just want to leave you with this, this little tidbit of data for you, so you can take this back to your practice and start really thinking about patients that are your wake-up strokes, your 5.5 to 24 hours, people with a NIH greater than 6, they need a CT perfusion. Here's the physiology why, and the data supports it.
Well, thank you, Dr. Francis. We really appreciate you coming and joining us with all the ischemic stroke updates and the CT perfusion. I think all of us needed a little bit more update on kind of all this new information, all the new imaging. I know we've had it for a couple of years, but I think it is coming up. It's a much more frequent thing that people are using, especially for interventional neuro, to get more involved.
Well, thank you so much for having me, everyone. I really appreciate you. And hopefully we'll get a chance to meet again.
Thank you, Dr. Francis.
Absolutely, thank you.
This was fantastic. I enjoyed the review. For everyone in the audience, just so if you enjoyed Dr. Francis' lecture, we are recording the event for our YouTube channel, and in case you need to review again. But Dr. Francis, it's been incredible having you here. Have an awesome morning, and we'll see you next time.
Thank you so much. Take care.
So I just have a few housekeeping items. As a reminder for everyone, again, thank you for joining us this morning. We'll have a break in a little while. And if you have any questions on how the event's running, please shoot me a text. But I think it's been very smooth so far. Feel free to use the Zoom function as well. Also, a big thank you to our sponsors today. We greatly appreciate both ProAssurance and Vapotherm. So next, I have the pleasure of introducing a colleague here in Saginaw, Dr. Belinda Kakos. Dr. Kakos, thank you so much for coming today. Dr. Kakos is core faculty at Saginaw with the CMU Emergency Medicine Residency. She's also an attending physician at Ascension St. Mary's and has skills in numerous areas, double boarded, and we're just thrilled to have her talk about the summertime today while it's still here. I hear rumors we have severe weather perhaps today with some thunderstorms in Michigan, so we'll see if we end up talking about the heat a little bit. Dr. Kakos, the floor is yours. Take it away.
Can you guys hear me?
Indeed, we can.
Okay, excellent. Sorry, thank you. So I want to take a minute to thank Dr. Mead for giving me the honor of the invite to share some thoughts with you on summer-related injuries that may show up in the ER. I'm going to present to you cases that I've managed in the ER this summer and look forward to answering questions at the end of the presentation. And what I tried to do was pretty much choose cases that were kind of in line and theme with our current talk today. In terms of incorporating stroke and the idea of telemedicine, only in so much as how it relates to COVID. So like we've been hearing ad nauseum, we're navigating healthcare in unprecedented times. Earlier in the year, we were advising patients to stay home. And now that we have somewhat figured out social distancing and PPE, although we're not completely figured it out, we've been advising patients to return to the ER and not delay emergent care based on fear of COVID. Recently, I've noticed that some of our patients have been coming into the ER for care, as many of their PCPs have had stricter guidelines in terms of who can come to the office. I've had patients say they were unable to go to the primary care doctor because they've reported a cough or an episode of shortness of breath, and so they come to the ER instead. And so this is how I came up with my topic. I've had an increase in outdoor and indoor sports-related injuries as patients have been using the time with having so many businesses closed as an opportunity to develop and pursue new hobbies and pastimes. The picture that I have here in the corner is about a year ago. I went to Banff in Canada and did a lot of hiking on Lake Pito. And so you can imagine the various injuries that people had along the pathway. So we're going to talk about fun in the sun and in the ER, and we're just going to keep this as a very light topic, more interested in learning about the different neuropathies that can develop. So not so much heat-related injuries. So in terms of our objectives, just delineate neuropathic injury patterns related to summer sports activities. We always I don't know how it is for you, but for me, whenever I hear paresthesias, I'm always thinking stroke. But we have a little small subset here in terms of our sports-related injuries. So I derive a lot of comfort in reading texts from some of our ancient scholars, and many of the conflicts and conundrums that we encounter are not new. They're just repeated motifs at a different time with new characters. And so I pulled a quote from Maimonides, which I thought was appropriate for our current environment right now. So we each decide whether to make ourselves learned or ignorant, compassionate or cruel, generous or miserly. No one forces us. No one decides for us. No one drags us along one path or the other. We are responsible for what we are. And this, of course, was said by Maimonides. So it's 7 p.m. in the evening, and you've been at your shift for a few hours, and you pick up Mr. Smith's chart. He's a 50-year-old male, comes into the ER saying he had intermittent numbness and tingling along the left side for the last few days. He has a past medical history significant for dyslipidemia and hypertension. He states that the numbness and tingling is provoked by movement and can occur while at rest. He denies blurry vision, double vision, transient muscle weakness, and diuretic use. He admits to increased stress at work. He tried to get in and see his PCP, but his wife did not want him to wait any longer, so he came to the ER. In terms of his vitals, his temp's afebrile. He has a heart rate of 80. He's normotensive at 130/80. His respirations are 60, and his SpO2 is 98% on room air. He's 5'10" and 120 kilos. In terms of your physical exam, it's pretty much unremarkable. He's A&O times 3, communicating clearly and cogently. There's no focal neurological deficits, just this strange feeling of paresthesias along his left side for the last few days. So in the ER, we manage probabilities under the context of risk. Oftentimes, with insufficient data and constrained time for our decision-making process, which could make the difference between life and death, optimal function, or disability. Pretty sure most of us, given this patient's presentation and comorbidities, would appropriately perform a stroke workup. And in this case, his CT was negative. He had no electrolyte abnormalities. You go back and talk to him about his results, and he shares a new routine he started. And this past the last few months, and he started short distance walking and hiking with a family. So here he is. So we know that paresthesias are neurological disorders characterized by painful burning, tingling, numbness, and decreased touch and pain sensation. There's no motor deficits. Backpackers in particular are at risk for particular paresthesias in specific distributions due to the compression of backpack straps, waist belts, and boots. They occur in both upper and lower extremities, and the development of the paresthesias are related to the duration of the hike, the distance of backpacking, whether you're in shape, out of shape, or have an overweight body habitus. So there are serious causes to paresthesias, and oftentimes we do what we must in the ER and rule out life-threatening causes, which we discussed, like CVA, complications from diabetes, certain toxidromes. But for a lot of patients that come in with paresthesia, sometimes the most obvious answer isn't a stroke. So hiking-related paresthesias. When we look at the cause of paresthesias in hikers, we note that they're pretty much related to repetitive overuse trauma and external compression of the nerves. And here are the 3 most common causes and sources of hikers' paresthesias. We have the backpack, the shoes, and then the waist belts that people may wear while they travel. So with backpacks, you get bilateral ulnar paresthesias associated with the tight backpacking straps that compress the ulnar nerves as they leave the axillary fossa. And this causes numbness and tingling of the 4th and 5th fingers. And it's been found and related to the weight of the pack. And there was one study done with hikers along the Appalachian Trail, and they found that the prevalence of paresthesias with packs between 10 and 20 pounds had about 30% of paresthesias. If your pack weighed 21 to 30 pounds, 50% would have and develop paresthesias. And if your pack weighed 31 pounds, there'd be almost 70% of the population would develop paresthesias. In terms of the waist belt, the most common paresthesia revolves around the nerve that's impinged, the lateral femoral cutaneous nerve, and this causes myalgia paresthetica. And it's characterized by pain, burning, or tingling paresthesias, and decreased touch and pain sensation on the anterolateral aspect of the thigh, again, in the distribution of the lateral femoral cutaneous nerve. The lateral femoral cutaneous nerve is vulnerable to entrapment neuropathy, where the nerve passes through the lateral end of the inguinal ligament. It's common in pregnant women, obese women, sometimes if people wear their belts a little too tight, but in particular with the waist belt for hikers and the fact that they're doing repetitive overuse movement, the nerve can become a little impinged. So in backpacking, this occurs when the external compression against the nerve is against the anterior iliac spine and the backpacker's waist belt is cinched. Now, in regards to shoes, this is a very important topic because I feel like for myself, at least, I'm always buying a different pair of shoes to kind of figure out how I'm going to be able to hike properly. But your feet are at risk for entrapment neuropathies, due to poor fitting hiking boots, as well as direct injury of the nerve related to repetitive trauma of walking itself. And so when your toes have paresthesias related to your shoes, it's known as digitalia paresthetica. You can also develop tarsal tunnel syndrome as an entrapment neuropathy of the posterior tibial nerve. Within the tunnel formed by the flexor retinaculum, the posterior and distal to the medial malleolus of the ankle, which presents as burning pain, tingling, or numbness at the medial malleolus with radiation to the heel or sole in the distribution of the tibial nerve. So here's another little schematic or pictorial in terms of the pathway of the nerves and at all the different areas where they can become impinged. So you can see here, if you're wearing backpack and it's really tight or heavy, you're impinging right at this area and you're going to develop your ulnar nerve issue. This is your lateral femoral cutaneous nerve. As it exits, here's the inguinal canal, or inguinal ligament rather. And if your waist belt is a little too tight, this is where you're going to experience myalgia parestheticas. And if you look here on the foot in terms of tarsal tunnel syndrome, you see that if you have a high top shoe or if they're on too tight, these are the areas that are subject. Here's the compressed tibial nerve that's subject to neuropathy. So hiking boots, in terms of the studies that they've discovered, hiking boots were the worst with about 70% paresthesia, and then it drops sharply for low top hiking boots at about 40%. Running shoes were a little bit lower, and sandals were at the bottom, less than 30% in terms of paresthesias. So really it's almost implying that if you're going to hike, you should probably pack really light and wear really light shoes as well. So in summary, in terms of our hikers' paresthesias, it can be related to back pain, or backpack, your shoes, your waist belt. The most common paresthesia locations are the ulnar nerve, the lateral cutaneous nerve, and the posterior tibial nerve. And in terms of management and treatment, it's pretty much time in terms of it being self-limiting. You're going to adjust your gear, you're going to want to travel light, and you're going to want to do NSAIDs. And these paresthesias can last up to weeks to months, depending on how frequent you hike and how attentive you are to listening to your body in terms of the pain responses that you're receiving or the paresthetic responses that you're receiving. So for our next case, we have a 45-year-old female that comes to the ER stating she's had right knee pain for the last few weeks. She's been getting progressively worse. She says that she had an old knee injury from a car accident, but hasn't had any new direct trauma. She says that she has a dull, aching pain in the front of the knee. She hears popping sounds when climbing stairs or getting up after sitting, and that she's afraid that her knee is going to give out if she runs up the stairs. She denies constitutional symptoms and she wants an X-ray. You review the x-rays of the knee and they're negative for any pathology, joint space is preserved. You tell the patient the results and she shares then that she recently purchased an indoor cycling bike and has been using it every day since its purchase. You determine that she has an indoor cycling related injury and then proceed to share some common injuries to be aware of. So in her case, she had patellofemoral pain syndrome, and this syndrome is multifactorial in nature, and it points into 3 different areas that can cause pain. There can be a biomechanical dysfunction of the actual knee itself and how you navigate space. There's a muscular dysfunction in terms of the connection between the ligament and the bone, and then there's also overuse injury. So in terms of biomechanical functions, what you want to consider is that patients that have flat feet and feet with high arches, and so by having flat feet, they have no support in the midfoot where the arch should be. So it gets an inward rotation of the thigh bone and the shin bone. And so this disrupts how the kneecap moves and causes an imbalance in the forces acting on it. So feet with high arches have less cushioning compared to those with normal feet, and this places pressure on the patellofemoral joint consisting of the kneecap and the lower end of the femur. So you can see in the little picture that I have over here, the area of pain that patients will comment on. In terms of muscular dysfunction, you can have weak quads, and that's a big concern, and weak, tight hip muscles, tight hamstrings, and tight calf muscles that also apply excessive force on the kneecap or affect the way it moves in relation to the femur. Overuse injuries with repetitive weight-bearing situations such as running, walking, cycling, going up and down stairs sometimes can be really painful for these patients. Pretty much what happens here is that the forces that act on the kneecap range from about 30 to 20% of the total body weight when walking up and up to 7 times the body weight during squatting. And so all this bending of the knee increases the This is why for some patients with patellofemoral pain syndrome, sitting for prolonged periods of time can also aggravate the pain. In terms of treatment, rest, ice, compress, elevate, but really primarily rest, ice, and use NSAIDs. And some people, you know, some sports medicine physicians are a little iffy on using tape, but you can use some medially directed taping in order to help the pain of the patella. And if your signs and symptoms persist, you can do some physical therapy, mainly strengthening the quad muscles. So your preventive measures as follows, and anticipatory guidance that you provide for your patients would be to ensure that while you're using the indoor exercise bike, that you ensure the saddle is not too low, that you raise the seat or move the seat back to decrease the amount of knee flexion, that you use shorter length crankshafts, and that you ride in smaller gears with higher cadence. And then, of course, perform muscle strengthening exercises, particularly related to the vastus medialis obliquus, and then accessing your quads as well, just to strengthen the muscles in that direction. The next indoor cycling related injury that we're going to talk about that has relation to the nerves is going to be called metatarsalgia, or hot foot syndrome. And so in this area here, you have burning and tingling in the feet. And it's a frequent complaint of cyclists related to how they actually cycle. And what you have is a compression of one of the smaller nerves of the forefoot against the metatarsal bones of the foot. So you can see here there's a little pictorial that shows that. So your causative factors include pressure between the foot and the pedal, wearing shoes that are either too tight, and improper positioning of the bicycle seat. Usually you can take your foot off of the pedal, and this should give you some alleviation of the pressure on the nerve, but you would almost have to be certain that you adjust the entire mechanics of how you navigate the bicycle. Otherwise, you're going to just re-injure yourself and create a neuropathy. You could also place a metatarsal pad on the insole of the shoe to relieve any pressure onto the nerve. In terms of preventive measures for this, when you do some anticipatory guidance for patients, you can reduce the intensity of the workout. You can consider changing the shoes to a larger size or with a different stiffness to the sole. You can again move the cleats back, you can lower the saddle, and you can change to a different type of pedal. The next indoor cycling related injury we're going to discuss is the bicycle seat neuropathy. So it's also known as the perineal or genital numbness, in which the pudendal nerve itself, you can see it exiting right through here, is compressed between the pelvis and the saddle. So it's a very, very common condition amongst cyclists, and especially after a prolonged riding or if someone is using a really narrow seat. And so the signs and symptoms, of course, are generally self-limited, as with all of these different nerve injuries. And it includes numbness, tingling, or pain in the groin or perineum. Some men may actually report some impotence. So in terms of treatment for this injury, of course, the common theme is alleviate the pressure. So you want to either adjust the bicycle seat or position. You can either tilt the nose of the seat down or lower the seat high up to relieve the pain and pressure off the perineum. You can change the style of riding. You can either stand up while you're doing your stand up from the actual seat itself, and then or just make periodic position changes. So while you're riding, you just know that you're going to do, after X number of minutes, you're going to change your position, and just make a very conscious effort to do that. That's how I would advise patients. And then of course you want to make certain that you can also raise the handlebars. That would force you to adjust your own seat or your own position within the bike. And then the saddle itself should be level. There are many different saddle seats and types of padding, but there isn't anything that has been specifically shown to alleviate this type of pressure. It's pretty much what you as the rider will tell you as the rider will do to adjust your own seat while you're riding. Okay, continue on with indoor cycling related injuries. We have here handlebar palsy. It's also known as Guy's canal or tunnel syndrome, cyclist's palsy, or ulnar neuropathy. Ulnar nerve is quite popular today. So this condition is caused by an irritation of the ulnar nerve at the hand and the elbow. And it occurs from stretching the nerve from either holding the handlebars a little too tight or for a prolonged period of time, or having direct compression from riding with the handlebars gripped in a certain position. And you know, there's a whole bunch of different ways that you can ride a bike in terms of its handles, and so you just have to be really cognizant, and which is what you would tell your patients, be cognizant of their position on the equipment. So in terms of signs and symptoms for these injuries, they typically include numbness and tingling in the 5th digit and in the 4th and 5th digit. And sometimes you can also develop weakness. And in this situation here, we again recommend figuring out when you start having these symptoms, adjusting your position. You can use NSAIDs and also add on some cycling gloves. They have some specific ones where there's gel cycling gloves that can, let's see, gel cycling gloves. Oh, okay. That can assist you in giving you some padding and alleviating the pressure on the nerves itself. I noticed that we have a question or chat. Anyone? Any biker experts? We have a colleague that finds short, thicker, breathable seat does make a difference. Okay. Okay, so in terms of how to mitigate this situation over here, so we said cycling gloves that reduce the pressure. You can do additional handlebar padding. You can attempt to change the handlebars themselves, or figure out how you alter your body in terms of the way you ride the bike. And then you can do hand exercises in between the rides themselves. So you can start getting one of those little squeezing iso balls and start using that to alleviate the pressure or work out the muscles. In some cases, extreme cases, you can do physical therapy where there is temporary splinting and rest, as well as the use of NSAIDs. And then if it gets really bad, you can see a sports medicine physician. They can do some corticosteroid shots. So in summary, our indoor cycling related injuries, we can develop patellofemoral pain syndrome, metatarsalgia, which is hot foot syndrome, bicycle seat neuropathy, and then handlebar palsy. And the treatment for all these would be rest, adjust your position, adjust your gear. You can take some NSAIDs and then do some physical therapy. So this last case that I'm going to present is a 50-year-old gentleman that came into the ER, and he was pulling out his fishing gear and decided that he knew where all of his equipment was and accidentally hooked himself. So I was going to open this up to the floor and see if anyone had any preferred practices that they'd like to share in regards to how they like to remove their fish hook injuries. String method. Thanks, Dr. Shalev. Advance and cut from Dr. Mead. Needle nose pliers from Dr. Phil. Okay. Yeah, I like to do the advance and cut method myself. I find it to be a little bit easier. And in this case, for this patient, it was actually a lot closer to the skin than what may reflect on the X-ray imaging. But I went ahead and pulled two different methods that seem to be really popular. I had pulled some of our colleagues, and the two methods that seem to be really popular are the string method and then the pull and clip. So in just real quick, string method would be you wrap a piece of zero nylon along the hook, secure it, exert a downward pressure on the fish hook to disengage the barb, and then while holding the nylon, forcefully yank 180 degrees from the site of insertion. And so it's often successful if you just yank it really quickly and not hesitate. And then, of course, the advance and cut technique is pretty straightforward. You advance the barbed wire, cut at the end, and go about your merry way. Everything okay? So, these are a couple more pictures from my trip to Banff. Are there any questions in regards to nerve-related injuries and outdoor activities?
Dr. Kagos, what do you think about for these injuries like diclofenac topical? Do you use a lot of that in your practice? Because I have so many patients that can't tolerate NSAIDs from either age or GFR issues.
I think they're excellent, to be honest with you. When I was in Canada, Voltaren gel was actually just over the counter. And I think they work great. I actually bought a couple tubes here for myself. But I think it's okay. I mean, it's okay to use. It's topical. I'm not really all that convinced that there's severe systemic harm from daily use. So Dr. McGowan says, I do a decent amount of biking, primarily triathlon. Definitely agree that shorter seats make a huge difference. Also, getting a true bike fit makes a massive difference. Having someone look at your body, mechanical body position while riding can make an uncomfortable ride become a great and comfortable ride. Yeah, I feel like there's been a large spike in indoor exercise equipment as a result of our COVID sheltering in place orders. And I've seen a lot of patients come in and say, you know, I have these neuropathies, which is what prompted this talk today. Any other questions?
Dr. Kagos, thank you very much. By the way, where are those pictures from?
From Banff in Canada. You got to go. You haven't seen, the Canadian Rockies are magnificent. There's a certain stillness to the mountains. The energy, it simply is not, it's not beat. I was very much a beach girl for the most of my life, but now I'm a mountain girl.
I absolutely love your pictures.
Thank you.
Thank you so much for joining us. It was awesome to have you here. I hope you can join some of the rest of the conference with us.
Thank you.
Thank you.
Thank you. All right, we are going to go into our next speaker. We just wanted to say thank you again to our sponsor, ProAssurance, for being able to provide our free CME today. Again, if you guys want to continue to utilize the chat function, if you have any comments or just want to engage the other listeners today, questions for the speaker, we'll be monitoring that. Go ahead and put them in the chat and we'll ask them at the end or kind of throughout the lecture if needed. Our next speaker is Dr. Baker. He's going to talk about some telemedicine and the COVID-19 response. He's an attending physician at St. Joseph Mercy Hospital in Ann Arbor, where he's core faculty with the U of M EM residency. He's the director of telehealth with EPMG and Vision. So he's been doing this telemedicine thing even before COVID started. Dr. Baker.
All right, well, thank you for that introduction. I'm going to get my share up here. And hopefully you can see it right now. Can we see it?
Yep.
All right, so we can see me, we can hear me, and that means we are ready to go. All right, so thank you for the introduction. Like I said, I'm really excited to be here. Telemedicine is something I've been working on for the last 6 years. It's been very slow going for the first several years, and then all of a sudden we had this huge explosion of things that happened during COVID-19, and all of a sudden telemedicine is everywhere. So I would like to just kind of share with you a little bit about the story of where we were before COVID-19 and what happened during COVID-19 regarding telemedicine and how that's impacted some of the programs out there that are designed around emergency telemedicine. I would like to also say that ACEP and the ACEP's telemedicine section has been greatly involved with developing a lot of these types of programs and developing a lot of resources, and also working with some of the government agencies to try to create some of the waivers that have been put in place for telemedicine. So I have nothing to disclose. Our objectives, like I said, is we're going to be telling a little bit of a story. So it's a little bit of story time today. We want to learn how the COVID-19 public health emergency accelerated telemedicine uptake within the country and within emergency medicine. We want to understand how telemedicine can preserve some of our personal protective equipment, help protect our patients and our physicians and also how it can benefit some of the operational metrics and front door operations of the emergency center. And then lastly, we want to be able to identify what are some of the key telemedicine workflows that emergency physicians can participate in, such as pre-hospital, EPPE, teletriage, and even some of the care transition programs. So our story really begins, like I said, before COVID-19. Teleconsults were sort of increasingly common in the emergency center. We were seeing telepsychiatry, we were seeing teleneurology, we were seeing even sometimes telepeds and other types of processes, but a lot of these were things that were brought into our emergency center rather than things that were emergency physicians doing things to patients with telemedicine. So ACEP really recognized that there were a lot of regulatory and other barriers to emergency physicians performing telemedicine. So we reached out to the ACEP and got a section grant to create a definition of emergency telehealth. And in this definition, we made some basic principles about the utilization of telemedicine in the emergency center and the value to patients of emergency medicine using telemedicine. And so just like many other things, emergency telehealth is a core domain of emergency medicine, and it is not something that we should be excluded from being able to do as we have been in the past. We also use it to remotely provide all types of care for conditions that are acute conditions of any kind. I know that we just talked about some of the summer health emergencies. You can certainly imagine how sometimes it would be helpful to have a boarded emergency physician who can try to help with some emergencies that may occur in remote locations. And that telemedicine should be able to occur regardless of any prior existing relationship. And that's important because CMS has always viewed telemedicine as something that happens only once you have a pre-existing relationship with the patient. So if you have a patient that you're seeing in the office, you could then do telemedicine. But if you didn't have that pre-existing relationship, such as what we do in the emergency center every day, they didn't feel that it was appropriate to do telemedicine. So we developed this paper, put this paper out. The paper was published in December of 2019. And at that time, we had absolutely no idea of how much things were going to change in 2020. We published that paper, and then what a ride we went on after that. So this is just a brief timeline of what we'll talk about a little bit today. So the first case occurred in the United States in January. By February, I was invited to participate in a national COVID-19 committee focused on telemedicine. By March, we had a public health emergency declared. We opened tents, we did curbside testing, we did waivers. We actually started implementing telemedicine programs such as teletriage. By April, we realized that we really were making a significant contribution by some of these telemedicine programs we were creating, and worked with ACEP to create a telemedicine field guide so that any other site that was interested in replicating some of these programs such as EPPE or teletriage would be able to do so. Also, CMS had a program that was supposed to start for telemedicine in April, and it actually was a program aimed at EMS and enabling EMS to get paid for patients that they leave at the scene. It was called ET3 for Emergency Triage, Treat, and Transfer. And this program was supposed to start in April, which we thought would have been really useful during the pandemic to be able to take care of patients and leave them at their house or wherever they're currently located, rather than bring them to the emergency center where you'd have to decontaminate the ambulance after they transport and all those sort of things. But CMS decided to delay that because of COVID-19. They didn't feel they had adequate resources, and they delayed that program until fall of 2020. By May, we were starting to see volume drops. We know that there were lots of areas that had high volumes, but in Michigan, we started seeing volume drops. Our tents that we had set up were retired. There was a lot of off-site testing available to take some of the load off the emergency centers. And then by June, we really recognized that one of the final pieces of the puzzle was, what do we do with patients after they leave the hospital? And how do we get them how do we get them ongoing care? How do we take care of these COVID patients once they leave? And so we started developing post-discharge virtual visit programs. And we'll go through those programs over the course of the next half hour to 45 minutes. So as I mentioned, the first case occurred in January 19th of 2020. This is the publication of that first case. That case happened in Washington State, for those of you who didn't remember where it all started. And when those programs, when COVID came to the U.S., there was a lot of experience that was developed in Washington State that was then moved over to New York when the outbreak happened in New York. And then we all benefited from that within Southeast Michigan because we were about 2 or 3 hours behind Southeast Michigan in that, oh, sorry, 2 or 3 weeks behind New York from Southeast Michigan. So the first thing that we ended up doing after we decided this was going to be a real problem for us is we developed the COVID-19 Response Committee. So the COVID-19 Response Committee had some very basic goals. It was to protect providers and patients. It was to ensure adequate staffing. It was to create rapid deployment of any resources. And it was to identify and break barriers. And so being the telemedicine person on that team, we identified a lot of barriers to implementing telemedicine to try to help with COVID-19. And those were regulatory issues such as EMTALA, CMS limitations such as the CMS had restrictions on the origination site where the patient had to be located in order to be paid by CMS. There were restrictions on pre-existing relationships, like I mentioned, and there were restrictions on technologies that were used and the need to be HIPAA compliant for those technologies. So as we go through this public health emergency, my birthday was on March 13th, which for my birthday, I not only received a lockdown orders, but I also received waivers from CMS and HHS. And these waivers, the first round of waivers was aimed at EMTALA. And these waivers were retroactive to March 1st of 2020. And the first thing they said is, there is no waiver of EMTALA. So we were expected during COVID-19 to maintain all the things that we currently do, and at the same time, take care of all these patients in a way that we haven't had to care for them before. But what they did do is they did give us a few breaks. First of all, they said that the medical screening exam did not have to take place in the emergency center, that individuals could be directed to off-campus sites, and also that the hospital was not responsible for EMTALA if we did set up a screening area for COVID, that those patients, as long as it was only for COVID evaluations, those patients were not subject to EMTALA. And then the other things that they did is they said that the medical screening exam itself could be performed by telemedicine. Now that was really important because we have postulated for a long time that there was nothing to prevent us from being able to use telemedicine for the medical screening exam, but nobody was brave enough to be the first guinea pig to try that. And so when CMS said, yes, you can use the telemedicine to perform the medical screening exam as long as it fits within the things that your hospital requires of your medical screening exam, that's when we were really off to the races and ready to get going on this. And the other thing that was important is they also said that just because you perform telemedicine out of your emergency center doesn't mean that EMTALA applies. So if the patient is not located at the hospital and you are in the emergency center performing these types of services, then EMTALA does not necessarily apply to that encounter. So the next wave of waivers came on St. Patrick's Day. And these were geared at what type of equipment, what's required, what are the technologies needed to initiate a telemedicine conversation with the patient. And essentially there were a lot of HIPAA restrictions put in place. You had to have these business associate agreements. You had to have all sorts of things put in place to utilize telemedicine before this waiver occurred. Once this waiver occurred, they basically said that you can use any non-public facing remote communication product. So you could use FaceTime, you could use Hangouts, you could use Skype, Zoom, Slack, anything that you want as long as it's a private conversation. They didn't want something where it was public like Facebook Live or streaming your encounters on Twitch and stuff like that, of course. So they were very specific about that. But it really opened up and enabled people to really try things using the stuff that they had, such as Zoom or such as WebEx or something, to be able to provide those telemedicine encounters. So what we ended up seeing with that is we actually ended up seeing people bringing their own stuff. So if I was a physician, I might have a subscription to a telemedicine platform that I used, and I would use that in the ER through my phone. And I could send the patient a text message that said, hey, connect with me using this video. and then I could do a video conversation back and forth with the patient. The next set of important waivers, and the last one we'll talk about for waivers, is the CMS payment waivers. And so, like I said, there were restrictions on telehealth payment. And so they initiated some waivers that enabled us to be paid for the telehealth that we do, regardless of if the patient was in a rural area or not, or whether the patient was at home or not. It really opened up the ability for us to do these two-way video conversations, but it did require two-way video. It had to be real-time and interactive in order to be something that CMS would pay for. They also removed the prior restrictions that I mentioned on prior relationships, so that you could potentially do this from an emergency center. And they also said some interesting things about what constitutes telemedicine. And they basically said that telemedicine is really a provider and a patient at two different sites. But if they're the same site, if you're both on site, but you're just using telemedicine to communicate with the patient, that's not actually telemedicine. That actually is a regular encounter in the eyes of CMS. And that also opened up a lot of possibilities for us that we'll talk about in a little bit. And I will skip ahead to the end just a little bit here, that because of the experience and efforts that we've had with telemedicine and emergency medicine, and the white papers that have been created over the last several months, and the work that we've been doing with ACEP, the proposed 2021 proposed physician fee schedule came out, and it is fairly favorable to emergency medicine. It does two things, and this is why this is important. One of the questions was always, when do these waivers end? And the answer has always been it ends when the public health emergency ends, which creates a little bit of a challenge because we're never quite sure when the public health emergency will end. Currently, it's slated to end at the end of October of this year. And what this proposed physician fee schedule included was language to say that the waivers will end the same year, at the end of the year when the public health emergency ends. So in other words, if it ends in October, the public health emergency ends in October, we'll be able to utilize these waivers till December 31st of 2020. If the public health emergency carries through until January or February, then we will be able to use these telehealth waivers through the end of 2021. The other thing that they said is that there are going to be three classes of things that are going to be different from the waivers. There are going to be things that are permanent changes that are not going to be continued. There'll be things that are permanent changes that will be continued, and there'll be things that are changes that are under review. So for emergency medicine, they did say that that the high-level emergency E&M codes are not going to be continued. So they will not use telemedicine codes, or will not accept telemedicine codes for high-level emergency medicine visits like the 99284s and 99285s. But they will review the low-level E&M codes 99281 and 99283. And I think this has a huge potential impact on emergency medicine and how we deliver care in the future. And it's really good news that they are going to put that under review, because when these waivers first came out, emergency medicine was left out of everything. And they really didn't think that emergency physicians were able to do telemedicine for emergency patients. And with all the things that have happened since then, we've been able to show them that it is a very valuable part of an emergency center experience moving forward. And we are really hopeful that with ACEP and with some of the efforts that we can do with lobbying and white papers, we'll be able to get those 99281 and 99283s changed from being under review to actually being accepted. So we're going to be working really hard on that in the future. So like I said, these waivers create a little bit of a question of if something is telehealth or not. So from the standpoint of CMS, if the patient and the physician are in two remote locations, then it's considered telemedicine, and it's billed under telemedicine codes, and you have to make sure that you document it as a telemedicine encounter. So basically, if a patient's at home and the physician's at the hospital, that's telemedicine. If the patient's at the hospital, physician's at home, that's telemedicine. If the patient's at one hospital and physician's at another hospital, that's telemedicine. But what's not telemedicine is anything that you could do as if you were conducting the visit through a window in the patient's room, for example, like a window in the door or an intercom or something. So if the patient and the physician are both located at the same site, and the physician's available to take care of that patient should they need to go in the room for something or examine something for that patient, or some limitation of telemedicine occurred, that's actually not considered telemedicine, and that's actually billed as a regular encounter. So what that enabled us to do is put an iPad in a patient's room, an iPad outside the room, and be able to do those visits back and forth for some of those patients that were at high risk. Because of these waivers, we also developed some documentation requirements that occurred to try to help with the billing process. So we came up with a few different elements that were necessary to document as part of any visit that utilizes telemedicine equipment. We wanted to make sure that we documented the location of the patient and the physician. We wanted to make sure we documented the type of telemedicine connection that was used, because only two-way video was paid. We wanted to document that there was consent. And in some cases, we want to document the duration of the encounter, because there are some telemedicine codes that can be used by the emergency center that are time-based codes. So keep that in mind too as you're creating any type of program for yourself. All right, so now I'd like to talk to you a little bit about some of the telemedicine programs that were affected by the waivers. And specifically, I want to talk about the Emergency Triage Treat and Transfer Program. So this was a voluntary program through CMMI. And basically, it was a delivery model that would enable ambulances to be paid for patients that were treated at the scene, but then not transported to the hospital. And they were going to pay for patients going to alternate care destinations like urgent cares, primary care physicians. And where we come in the emergency center is telemedicine. So we would be providing the medical direction for these cases about where to go. And we might even be able to provide the virtual visit for these patients at their current location without having to transport these patients. So it was supposed to be a 5-year program that started in January. It was delayed till April, and then with COVID, it was delayed till fall of 2020. They have not officially started this program yet, so it is still technically under delay. But if you are a program that has applied and been approved for ET3 already, you can apply for a waiver right now to start your program. So they are accepting applications for waivers to try to get these programs up and running. So this is a diagram from CMS that shows sort of what the ET3 model goals are to encourage appropriate utilization of emergency resources, to increase efficiency in the EMS system, and to provide person-centered care at the most appropriate level. So what does this mean? Well, the orange is the old way, and the orange is how we used to get paid and how EMS will continue to get paid through basically seeing the patient and transporting to the emergency center. The blue is the ET3 model intervention, which basically enables ambulances to go out, do their protocol treatment for those patients, and then decide if the patient needed to go to urgent care, ER, or even a telehealth encounter. And if they can keep the patients at home or send them to an alternative care destination, EMS can still bill for the encounters that they have. So you think about patients that have had insulin reactions and they're hypoglycemic, that have had mild asthma exacerbations, where those patients are treated, seen by EMS, and then they refuse transport. Well, those patients then could become patients that actually are billable visits for those EMS agencies, because you could do the virtual visits, you can do the encounter with those patients on scene and keep those patients on scene. So those are patients that we can bring back to our emergency center that we might not be seeing right now because people are worried about coming to the hospital, and we can treat them actually in place. And so there's a real advantage, I think, to us. Now, there is obviously some risk involved with this as well, in terms of making sure we maintain our volumes within our emergency centers. But really, this is trying to do the right thing for the patient and trying to make patients that don't need to come to the hospital, don't need to be at risk for the transport risks and everything, and keeping those patients at home and in place. So we had a precursor to this. We created a community paramedic program in the Southeast Michigan area with a ambulance company called Huron Valley Ambulance. We were able to get grant funding for a demonstration project. And then that grant funding was eventually used to talk with the private payers and get private payers within the state of Michigan to be willing to pay for these types of encounters as well. So that for us was fantastic, fantastic progression. So I'm just going to show a short video, and I don't know if it's going to work. I just got a message on my my Zoom that the bandwidth is restricted right now. So if this doesn't work, someone message me, okay? So I'm going to show a short video about what this looks like. All right.
Going to an emergency room is quite.
Apparently I won't do it because the bandwidth is too short. So let me get back to my thing. Okay. So this is basically what happens though. So we had a specially trained community paramedic that had a unit that had all the equipment on of a normal encounter. And when 911 got called, if the patient met criteria to have a community paramedic go out, the community paramedic was sent. They would then do the evaluation of the patient. They would do whatever they could do by protocol, give them nebulizers, give them glucose if they had to, whatever that protocol said. And then they would contact the emergency physician, the emergency center for medical direction, and then a video visit as well. So if the patient was felt to be someone that could be kept at home, we would do a video visit to keep that patient at home. And then after the end of that encounter, the physician would decide if the patient could stay at home, needed any new medications, or needed to come to the hospital after all. So it was quite an interesting program. What we've discovered is that the community paramedic was able to see a wide variety of complaints. This is a Word document of Word diagram of all the different complaints that we had. We included things like vomiting, fevers and flus, urinary symptoms, mobility problems, weakness, falls, dizziness, just a whole bunch of things that they were able to see. And we put all this together into a presentation and presented the findings. And what we found was that out of the 2,000 patients that we included during the time of the study, 53% of those patients were able to be treated in place successfully with telemedicine. And so that's a huge savings to the system. That represents a savings of approximately $2.3 million in saved transport and emergency center costs. This program had really high patient satisfaction, and we had no adverse effects with this, adverse events with this program. So where do we go from here? Well, this program was a pilot program, like I said. It was grant funded, and now we have private payers and CMS all interested in paying for this program, which puts us in a right position to expand this program. So we're going to go from basically one ambulance who's doing this work to all the ambulances doing this work within our region. And they'll all be able to initiate a telemedicine video call back to the physician and have that video visit to determine if that patient can remain in place or not. So we're going to start that probably in November of this year. And so there's more to come on how that turns out when we sort of turn up the heat on that program and really expand it. So the getting back to the story of COVID, so that's how COVID sort of affected those types of pre-hospital programs. But once the COVID-19 started and we started seeing those uptakes, we really wanted to see how could we protect our providers and our physicians and our nurses within the emergency center. And we decided that we really needed to initiate electronic personal protective equipment. And so that was one of the first things we did. It was one of the easiest things we did because all it required was the simple connection between the patient and a provider. And we could use a laptop in the room with a web camera. We could use an iPad in the room. We could use FaceTime. We could use all sorts of different platforms that were out there and readily available to do this. We even had people bring in their own platforms like we talked about. And I will tell you that it's enormously satisfying to be able to see a finding on my electronic medical record and then click on a link and get into the patient's room with that patient right away and explain what's happening with that patient, give that patient an update. It's wonderful to be able to do that right away and not have interruptions that happen between when you find that finding and when you get up from your computer to walk across the ER and you have 2 or 3 people ask you questions or ask for other things as you're trying to get over to that patient. It's really satisfying to not have those distractions when you do this. So that was one of the unexpected benefits of being able to use video for electronic protection equipment. So just after we created our use of telemedicine for EPPE, a physician named Robert Turr, who's an emergency physician at Vanderbilt and who's one of my former residents actually, published a paper on the theoretical use of electronic personal protective equipment for COVID-19. And this was really, helpful for us because he had the theory that he published and we had the practical. And so we got together and sort of hammered out some of the things that I think are really important learning points on these. And one is that you do have to have two-way audio video to make this work. It reduces the amount of time spent within the 6-foot radius of the patient. So even if you feel very strongly that you need to go in that room and do a physical exam thing or do a procedure or something, you can use telemedicine to decrease the amount of time that you're within that 6-foot radius, that danger zone of exposure to a patient that may have COVID. It's used very similar to looking through a window and a door. We did find that in COVID-19 specifically, there is limited value of a stethoscope. So one of the things that's important is don't let perfect get in the way of making a program work. So if you can accomplish 80% of what you need to do with the telemedicine stuff you have, don't wait for that perfect thing. Don't wait for that stethoscope to come to complete your package. You can work on that later as you're already using what you have. So we do know, and most of us have already had this experience with COVID-19 patients, that when you get COVID, when you have a patient with COVID-19, the physical exam, the lung exam specifically, the auscultation, really lags behind some of the other findings like the pulse ox, the work of breathing, or even the chest x-ray findings. So we really don't feel that in this particular pandemic that the stethoscope is particularly helpful for PPE, but you can use one if you like. And remember, if the patient and provider at the same site, it's billed as a normal emergency visit, but we do need to have some more studies on how much it actually preserves PPE and also how much time it preserves from getting in and out of the personal protective equipment. So the other thing it did is it helped keep families in touch with their patients. So during COVID-19, we know that there were emergency centers that were shut down to visitors and only the patient could come back. And in keeping with the prior lecture's theme of summertime emergencies, I had a personal experience with this, unfortunately. And my own daughter, after she graduated from high school, decided that she was going to learn how to do some kicks and flips with a skateboard, and managed to dislocate her elbow. And so we went off to the emergency center, and there was not we couldn't have a lot of visitors, so we were able to keep in touch with family back at home with what was happening and what was going on with her through the video that we had on our iPhones and other devices, and through photographs and such. And so she came through it okay. She is now at University of Michigan. I just dropped her off yesterday. And here she is sporting her University of Michigan sling just a few days after she dislocated her elbow. She's in a long arm cast there, as you can see. And this is her in her non-prom prom dress. So we took some non-prom prom photos with her University of Michigan sling in place. So it really is helpful to patients, if the patients going up to the floors, patients in the emergency center, it really is helpful to keep patients in touch. So after we did this, we started looking and saying, well, what else can we do with telemedicine? And we looked at triage, and we wanted to see, well, could we help with triage? And so we looked at some of the different papers that were out there for starters, and we really discovered that, yes, it is really helpful to use telemedicine at triage. And so this paper by Dr. Izzo basically compared in-person and teletriage, and really discovered that really there wasn't a big difference between in-person and teletriage as far as their primary outcome, which was how often are orders changed by the person who actually ends up seeing the patient and back. And so they found that for both the tele-intake and the in-person encounters, less than 1% of orders were canceled by the second provider. So that was good. That meant that we were able to get some accurate information using telemedicine to see these patients and be able to initiate their workups. So then Dr. Joshi, who's out of Thomas Jefferson, has published a few studies on tele-intake and teletriage. And this particular study showed that there is a little bit of a learning curve. It does take several weeks before you feel comfortable enough doing teletriage that you sort of match the patient per hour speed of an in-person tele-intake person. But the good news is that you can get there. So there's not a lot of difference between speed of having an in-person provider versus a tele provider. The other interesting thing that came out of this particular study was that even though you had that intake person, whether it was telemedicine or in person, taking care of that patient and getting those orders started, when they used telemedicine, for some reason, they had a decrease in their left without being seen patients. And they postulate that some of that might be due to getting to that patient a little more quickly with telemedicine than with the in-person service, and also the increased focus that you have when you're doing telemedicine, because you don't have the other distractors around you slowing you down and distracting you from that patient that you're seeing in front of you. So those are some of the reasons why they think that they found some improvement there. And then they actually did another study where they implemented telemedicine at a site that didn't previously have telemedicine, and they implemented it from 11 a.m. to 6 p.m. every day, and they used it for teleintake. So they compared no teleintake and no provider and triage to a teleintake model. And these numbers that you see in front of you are 24-hour numbers, even though the service only occurred from 11 a.m. to 6 p.m., which was sort of their peak volume time. And so overall, they saw a drop in their left without being seen rates, a drop in their door-to decision times, and their AMA rate stayed the same. Now, they were concerned that their ED length of stay stayed the same, but they did explain it in that they didn't really add any other resources to the department. So any orders that were done or anything that was ordered for that patient needed to be done with the same number of nurses and techs and radiographers. And so they postulated that the ED length of stay did not change, because although we were able to get to the patient more quickly and decrease the door decision time, that all the other parts of the emergency center needed to also function in concert with it. So just doing orders alone isn't going to decrease your ED length of stay, but doing orders plus adding additional resources to get those orders executed might help. So we took all this information and created our own teletriage, and in some sites we actually created a curbside visit program. And what we actually ended up doing was combining a lot of these waivers that were out there of using offsite, using telemedicine. And we set up a couple tents at one of our hospitals. One tent that you see on one side, the yellow tent is the tent where the patients went, and the blue tent is the tent where we did some diagnostics like an X-ray or an EKG. We basically split patients off as they were entering the emergency center. If you had a non-respiratory complaint, you were brought back to the emergency center and back to a room. If you had a respiratory complaint, you went into the tent for screening. And the reason why we did this is we were seeing a lot of walking well patients that were just worried about what was happening, that really didn't need the full services of the emergency center. But we also wanted to make sure we maintained EMTALA and maintained the need for that medical screening exam. So we set up an in-touch robot in the tent. And here's an example of where the patient would be and the in-touch robot. And then we had the provider would be sitting back in the emergency center and seeing those patients that came through the tent. And they would be able to do the evaluation and talk with the patient about how to take care of themselves if we thought they might have COVID. And then if we thought they needed an X-ray or EKG, we could get that as well, give them their discharge instructions, and then they could leave the back of the tent and go back to the car without ever having had to come into the emergency center. And why was this helpful? Well, not only did it enable us to take care of a large volume of patients that were coming to the emergency center, but it also allowed us to keep those patients from coming back and contaminating the rest of the department or interfering with other patients. At the same time, by using telemedicine, we actually had sites that had single coverage providers, and we were able to use the provider in the tent and in the emergency center at the same time by basically letting that provider beam into the tent instead of having to put on protective equipment, go into the tent, and then come back out of the tent to see the patients back in the ER. So it really provided that isolation of that provider so they didn't have to keep going back and forth. Or were able to continue doing their duties within the emergency center as well as they saw some of these patients in the tent. So that was really, really helpful for our workflow. And then when the patients were brought back to the emergency center, if we thought they needed more care, we could give a warm handoff to the accepting physician that was going to take care of that patient. So around April and May, we got a few of us together that are doing this type of work and really decided that the ACEP telemedicine section really needed to come up with a guide on how to do these things. So there is a ACEP telemedicine resource called the ACEP COVID-19 Field Guide. Within that guide, there's a whole section on telehealth and teletriage and some of the things to consider when trying to set up a program. And we really wanted to make sure that this information was available to sites that were interested in doing this. So what are the next steps? Well, the last part of this was the idea of the transition care. So how do we take care of patients that are leaving the emergency center? We have seen that there is some health inequities that are happening between certain groups, that some groups are doing better with COVID-19 and some groups are doing worse with COVID-19. And part of that may have to do with access to care. And I think it's really important that we provide the same access to care to all the patients that we see in the emergency center. So we are setting up a program to see patients virtually that have left the emergency center that may have COVID-19. And the reason why this is important too is because some of the primary care physicians' offices are not really set up to be able to see patients in person that have COVID-19. And so they're kept out of those offices and kept out of follow-up. Plus, a lot of the primary care offices are not accepting new patients during this time, which makes it difficult for emergency patients who don't currently have a physician to get that follow-up. So we developed a transition program that any patient with symptoms that had COVID-19 or laboratory diagnosis of COVID-19 could be put into. And we're really trying to help transition the patients back to their primary care physician. We can contact the patient with a text or email to connect them with the physician. And the patient will have the opportunity to be reassessed up to every 24 hours. And typically patients only take 1 or 2 visits for this. If the patient has any smart devices, like a watch or a thermometer or blood pressure cuff or even a pulse ox, we can use those to try to help take care of that patient. And then any patient who's determined to have a declining condition can come back to the emergency center for further care or be referred to somebody else. So we found really through our pilot, there are really 4 key components to a program like this and 4 key steps in terms of getting that patient the care that they need for follow-up. One is at the point of discharge. So at the point of discharge, it's really important to explain to the patient what we're doing and what to expect and what the opportunity is for them to re-engage with the physician. And so the next step is re-engaging with that provider. So after the patient leaves, after you've decided that you're going to do a follow-up with that patient, the provider then would reconnect with that patient through a text or email message or some other way. Sometimes it's done through a portal, but reconnect with that patient in a way that's easy for the patient. We did have concerns that if the patient had to download a lot of things on their own personal devices, that it would be an impediment to getting the patient to return to that visit. And so we tried to select software and packages that wouldn't require a download, that we could just send a text message and the patient could click on a link and be connected with us. And then we did the consultation, and like I said, you can use any devices the patient had at home. We can use the video to look at the patient's respiratory effort, how easily are they speaking. We can assess their heart rate by just having them count out their heart rate over a few second period. We can, and if they have obviously if they have a watch or something that can tell them that, we can use that information, check their temperature, use a pulse ox as well. And overall, how do they appear? Do they appear like they're doing okay, or do they look like they need some more help? And then lastly, we documented this within the hospital record so that we could have a record of it should the patient need to come back to the emergency center later. So, this wasn't just for COVID-19 patients. This is obviously COVID-19 patients, but patients might have diabetes complications. They might have a cellulitis that you're discharging them home and you want to have a recheck in 24 hours. They might have other comorbidities such as CHF or asthma that you need to monitor. And so those are really, I think, important resources to be able to give to that patient after they leave the hospital. So where are our take-home messages? So there are opportunities for emergency telemedicine and emergency physicians to perform telemedicine, including pre-hospital, tele-intake, EPPE, and transitional care. I think those are really programs that you should really be thinking about moving forward in the future. If a patient and provider are both located at the same site, CMS does not require the use of any telemedicine codes to bill the encounter. You can just bill as a regular encounter. It's considered personal protective equipment. Telemedicine can satisfy the requirements of the EMTALA and the medical screening exam. Teletriage can decrease door-to provider times rather, and improve patient satisfaction. But overall, we do need more research to show how emergency physicians and our patient can benefit from emergency telemedicine during COVID-19. And just to help everybody out, there are several resources out there. ACEP has 2 of them. One was done by the informatics section by Dr. Todd Taylor, and the other one was the ACEP COVID-19 field guide that I mentioned that I contribute to with Dr. Sheehan. And then there's two other resources I'll point out. One is the National Consortium of Telehealth Resource Centers, and the other is Center for Connected Health Policy. So as you can imagine, there are not only federal rules, which is mostly what I talked about today, but there's also state rules that apply as well. And these two resources tracking all the changes in federal and state rules for telemedicine. And so it's a really good resource to reach out to if you're planning on starting something within your own state. So with that, I am at the end. I am Michael Baker, Director of Virtual Health. And that's my email address and my Twitter and LinkedIn. Please feel free to follow me. I sometimes send out information on telemedicine and other related topics. And I will be happy to take any questions if there's still time.
All right, thank you, Dr. Baker. If there's any questions, go ahead, type them in the chat. I guess I have a couple of questions. When you're using the EMS out at the house and they're like treating and you're doing a telemedicine visit that way, how is that decreased your ER visits? How is that happening?
Yeah, so it hasn't really decreased our ER visits, in part because we can build that as an encounter.
Okay.
So when the EMS is out there, it's something that's still a billable encounter. Now, does it decrease the volume for the hospital and the hospital side? Yes, it can. If you use the hospital's equipment, the hospital can recoup a small amount for providing the telemedicine equipment, so they can actually bill a fee for that to the patient for the use of the telemedicine equipment for that encounter to recover a little bit of that. But yes, it is possibly going to decrease some of the actual visits that you see. But ideally, what you'll be doing is being able to focus your resources on the patients that are receive most benefit to the emergency center and are the ones that really do need the care. Because if we can take care of them at home, then they possibly didn't really need to be in the emergency center.
How about for refusals of care? Because you always get those phone calls from EMS. Have you been able to like incorporate that into like patients whose family members call, but then they refuse to come in, like having a face-to-face conversation rather than over the EMS line?
Exactly. So, refusal of cares are one of the things that they were actually looking at for this program and really looking and saying, well, if we get someone who refuses to come in, but really did need some interventions and did need an evaluation by a physician, we can still offer them that, and they can then have that video visit and get paid for that encounter. Now, of course, if they absolutely flat out refuse everything, then that's a problem for both the EMS and for us, in that we won't be able to collect anything for that if they're totally refusing, because consent is always necessary to treat patients.
Okay. What have been your biggest challenges with developing this program?
Really, the biggest challenge has been the regulatory hurdles that are out there. So the waivers that have been put in place really gave us a window, an opportunity to really say, let's really put some of these programs out there and show people what can happen. And so we are working on collecting data and information from these programs about how does this really help emergency care? How does this help patients? How do we help reduce cost of care for these patients? And I think that's really the important thing that we're going to come out of this. And so a lot of people working on these telemedicine programs are trying to collect this data and trying to come up with white papers and published papers and all sorts of things to try to support the work that we're doing. Mm-hmm. It has been successful. Like I said, we have worked with the telemedicine section and ACEP, and HHS and CMS so far has been listening to us. It was fantastic that early on they left emergency medicine completely out of the possibility of using telemedicine, even though 90% of the visits were converted over in the early days of the lockdown to telemedicine visits. Primary care offices were using phone calls and video calls, but we were not able to do that. And so while our volumes plunged, we couldn't reach out to a nursing home and provide support to a patient in a nursing home, for example, to try to help take care of that patient. But now we will be able to do that under the waivers, and hopefully with the information we gain, we'll be able to keep those some of those things in place.
All right. How many visits are you guys doing each day? Like kind of now that the COVID volumes are down a little bit, are you guys still utilizing this a lot for follow-up visits? And
Yeah, so our follow-up visits, we're doing about only about 5 patients a day for COVID for follow-up, but part of that is because the volume has really dropped down on COVID patients, although it has since come back up. So we sort of had a dip back in June, July, and then it's coming back up. So we are certainly seeing an increase in that program. For the ET3 program, we're anticipating that we'll probably be seeing somewhere around 12 to 15 patients a day via telemedicine. So that'll be 12 to 15 encounters that we can add to the care that we're getting, especially when patients are reluctant to come to the emergency center right now.
Do you have a separate person like in your shift schedule that is like set to do those telemedicine visits, or is it kind of like during your normal routine, like daily, you're seeing patients in the ER and taking these telemedicine calls from EMS?
Yeah, so the hospital that we have it set up in is a hospital where there's multiple providers available. So we have several physicians that work at a time in the emergency center, and so it's not single covered. So as a result, we do have one physician who's primarily assigned to take those calls. But if for some reason that physician is tied up in a code or tied up with a patient, then one of our other providers will come over and assist and help with that call.
I'm not really seeing any more questions in the chat. Anybody have any other questions they have for Dr. Baker? All right. Thank you.
All right. Well, I thank everybody, and keep staying safe, everybody. Thank you.
Thank you. All right. Thanks everybody for listening. We have a great way to maybe start doing some more telemedicine in our own ERs. We are going to go into the break a little bit early this time. We're going to do about a 20-minute break. So we'll be back maybe about 11:30, 11:35. During the break, we're going to have our shout outs that we had for our first session play. We have some shout outs from the governor and our senators that will play in case you missed them with our last session. Just try to stay on. If you guys want to turn on your video, maybe chat with everybody else. If you guys want to type in the chat, or you can even chat with each other, turning on the volume. But we'll see you back around 11:33 or so. Okay, thank you.
Maddie, the audio is not coming through yet.
Okay. I'm not muted, so I'm not sure why it wouldn't be working. Can you see it?
Yes.
Okay, I'll try again.
Yeah, I don't know if maybe it's a bandwidth issue, because in the beginning it goes for a moment, then the audio just cuts.
It's still not working?
No.
Okay. Do you think maybe I have to take my video? Let's turn my video back on and see if that makes a difference. Okay.
Seems like it's going to be a no-go. We can either just hold off and try it again later and do the other slides perhaps.
Okay, yeah.
It sounds like your microphone is trying to pick up the audio, that it's not playing the audio directly from what it's playing.
Okay.
So I don't know if there's another way you can do the audio some other way with a phone call or something.
I was going to say, I'm doing it exactly how I did it last time, so I'm not really sure why it's not working.
Well, could be the same reason mine didn't work.
Yeah, that's true.
Yeah, I can try to play them at 11:30 if people want to take a break now, play the other slides.
Okay.
And then I'll see if I can get the videos up around 11:30 for the shout outs.
Okay, I'll keep playing with it.
Okay.
Nice work, everybody.
All right.
I want to thank all of our emergency physicians on the front lines for protecting Michigan families and saving lives over the past 4 months. You have showed unwavering strength, humanity, and grit throughout this crisis, all while putting your own health, your own lives on the line to protect the rest of us. We would not be able to get through it without you. Thank you.
To all of my friends with the Michigan College of Emergency Physicians, thank you so much for everything that you have been doing always, but particularly during these last number of months and as we continue on in this pandemic. I don't need to tell you how tough it is. You're on the front lines. But I will tell you, as somebody whose entire family's in Michigan, I'm extremely grateful for your incredible hard work, your dedication, your competency, your courage. To me, that defines a hero. So thank you.
Hello, I'm U.S. Senator Gary Peters, and I'd like to take a moment to say thank you. You're on the front lines each and every day helping us get through this pandemic. You have stepped up selflessly, and you are a big reason why I know we will emerge stronger than before. That's why I'll keep working to provide essential workers a well-earned raise, personal protective equipment, and other resources to ensure you can continue to do your job safely and effectively. Thank you again for all that you do.
Greetings from the ACEP branch offices in Florida. I would much have preferred to be giving this message to you directly from the balcony of the Grand Hotel, but times have changed. First, I want to thank you for everything you have been doing and will continue to do to help emergency medicine in your communities. I hope you're all doing well, and I know at some point in the future, we'll be able to meet again in person and talk through the things that we've been doing this year. So I wish you well in your conference, and until we meet again.
All right, we have one more. This one's just audio, so I'm going to play it and hopefully everybody can hear it.
Hello, everyone. This is Walker Foland, ER doctor at Covenant Healthcare in Saginaw. Emergency medicine is a temporal specialty. It is a specialty of time. We thrive on putting out fires in every organ system, in every disease process in medicine. We don't own a location of the body like other specialties. We own the emergency. This pandemic has highlighted our strengths. We stand up when others fall. We go toward the danger when others run. We find ourselves at our best saving others and when no one else is there to do so. And we face these dangers not out of fearlessness. We face these dangers because we can, because we have to, because it is our duty. Not out of fearlessness, but out of bravery. We feel the fear of COVID. We have seen it kill our friends, our family, and our coworkers, and yet we continue to stand up to it. Trust me, we all feel the fear of COVID, but we confront our fear, and we do what we were put on this earth to do. We are emergency medicine. We own this pandemic, and in the end, we will win because we will never give up and we will never falter and we will persevere. I've never been more proud of our specialty. It's an honor to go to work every single day. And I'm no hero, but I work with them every day.
All right, well, thank you. Thanks, Abby. We're going to get started again. It's 11:35 right now. We've got Dr. Mead that's coming up. Again, hopefully you guys were able to look at some of the slides that were put on the screen that kind of giving our updates for our next event, which will be the third one on the 30th of September, as well as a few other information was on there as well for MCEP. So to introduce Dr. Mead, obviously she's one of our summer series co-directors and works with the MCEP and works with the Education Committee for a long time now. She's also Associate Program Director of Emergency Medicine at Central Michigan University in Saginaw, an ultrasound guru, and also a practicing EM physician in Saginaw, Michigan as well. All right, thank you, Dr. Mead.
Thank you, Dr. McGowan. How's the audio? Excellent. So it's good to be back, and it's actually great to be here to speak on a topic that I really enjoy, tranexamic acid. Now I'm going to have a little fun with this. I've decided to tempt the technology gods, and I have implemented some pull everywhere into my presentation. So as with all technology, I expect to succeed, but I always have a backup plan. So let me know how it works. So while I'm getting set up here and getting ready to share my screen, if you have not used pull everywhere before, you'll be able to go to pollev.com. I'll bring up the screen in a moment, but that will be POLLEV.com. And it's going to give you a little number to put in the system, and that will link you to all of my polls for the day. So there will be a handful just to get some conversation going. I know, especially with us muting the video, it's kind of hard to interact a little bit. However, on the same token, I think this will help you connect. And feel free to also chime into the group chat. I will be watching that. Or if you want to ask a question mid-talk, we have a lot of time. So I don't mind if you unmute for a moment. So let me set up and get shared. But if you have, again, you'll probably want your smartphone for this. I think it'd be hard to split your screens. So get your phone out and get ready, because I'm going to have you off and on pull everywhere throughout my talk. Okay, Jeff, do you have my slides? You see them?
Yep, we're looking good. I see him.
Perfect. My thought is this, just because of how exciting technology can be sometimes, I'd rather just check it out in the beginning, because you never know. So let's talk about some fantastic TXA, my top 10 tricks. I have no disclosures, except one warning that I have the distinct pleasure to talk about some non-FDA or off-label approved uses of a medication today. And you are forewarned of that. So first, a huge thank you. This has been awesome to see everyone today, at least your names on the screen. But to break the ice and to see if Pull Everywhere is going to work for us today, let's try this first. And again, go to pollev.com. I'm going to pause here and get everyone a chance to make sure the poll is working. /Therese Mead 538. And let's see if we can find out where any of our guests are coming from today. So go ahead and give that a try. Oh, it is working. We've got some Michiganders here. We have some East Coasters. Let's keep going. Where is everyone coming from? And we'll keep this going for a minute or so. Someone's from way south. Where else? All right, I'll put mine in here. Another plug for Michigan, lots of Michigan. Keep going, lots of Michigan. I was curious how far our reach was today as we're building these events. West Coast made it in, welcome. Give it another 60 seconds or so everyone can get comfortable with the app and get using it. I see our far south guest has left us already. I was questioning that we're really where we said we were. Awesome. So a lot of Midwest. Okay, so I'm going to pause it here, but now you know how to find PO everywhere. It is great to see everyone. And again, thank you so much for coming out. I know it's not the same as in person, but these have been a lot of fun for me too. So let's try another one then. Now that we've woken you up. Of the following choices, which is your least favorite complaint to manage all alone in the emergency department at your favorite freestanding shop? Let's give this one a try. Your favorite, your least favorite. I'm going to give you a hint. I gave you almost all of my least favorites. Post-op tonsillectomy hemorrhage seems to be winning. Yeah, those are not much fun. My thought with those is they're usually young patients and they can be super sick if you've seen one. Surprised no one said bleeding AV fistula yet. Oh, there we go. Thank you for putting that one in there. When those start spurting, they're not much fun either. But apparently the fingertip is not a problem. All right, well, as we talk today, I'm going to give you some tips and tricks using TXA to help manage each of these problems among some others. So what is TXA? This is it. This is its structure. And basically, it is a lysine analog. And it acts as an antifibrinolytic, stabilizing the fibrin matrix. And it's been discovered many, many years ago. It is not, as you may know, it is not a new drug at all. Dr. Okamoto from Japan actually discovered this drug as they were researching postpartum hemorrhage and ways to improve maternal mortality back in the 1950s. In 1962, they published their findings in the Keio Journal of Medicine. Again, it took a long time to get acceptance for the treatment of tranexamic acid. And it wasn't FDA approved in the United States till 1986. There have been a whole variety of massive trials. I think you're probably familiar with the CRASH 2, and we'll talk about that using TXA for hemorrhage. And in 2017, the Woman trial was published showing some benefit in postpartum hemorrhage. Again, that was the indication that Dr. Okamoto had been looking at in the first place. There are only a very few indications for TXA actually from the FDA. And I wanted to share them because honestly, I use it for so many other reasons. You don't realize, I guess, how often we're doing a lot of off-label work. But TXA officially in the IV form is approved as an antifibrinolytic for patients with hemophilia for short-term use to prevent or treat hemorrhage. And then also following tooth extraction. So that's it. That is the only indication for IV TXA to this day. Now there is an oral formulation, and that is only indicated for heavy menstrual bleeding. So that's it. Everything else we talk about, again, you're forewarned off label. There are a few contraindications that you should be aware of before we delve into why I use this drug and what I use it for. And one interesting one that I would not have known about is acquired defective color vision. You should not use TXA for that, nor subarachnoid hemorrhage, active clotting, or of course, if they have an allergy to the medicine. There are a few warnings on the labels as well that you should be aware of. Don't use with combined hormonal contraceptives, and you need to adjust or consider adjusting your dosing if they have renal disease. There are a few side effects. I have not seen any yet in many dozens of doses for many indications, but DVT and PE are the biggest concerning and serious side effects. If you're pushing this rapidly, you may also have some hypotension, and dizziness can also be a common side effect, especially with people on the oral formulation. Topically, I would not expect that. Nausea, vomiting, and diarrhea can be expected, as well as some menstrual discomfort and chromatopsia, which brings me to my next poll. All right, what is chromatopsia? And this is what I find out who's on LSD. All right, absolutely. So this is a change in seeing colors. And I thought that was my fun word of the day. So I thought I would share it with you. So it is time to go off-roading. Now we're going to talk about all the different things that we could do off-label with TXA and that have really been truly life-saving. So my top 10 tips and tricks for TXA that I will share with you today. Number 1, So major traumatic hemorrhage. Now, this is maybe not the most exciting use of TXA, but this is the one that's the most important. So that's the one that I felt has to be number one. The CRASH 2 trial that I mentioned back in 2010 was a massive trial and has gotten a lot of publicity, and rightly so. It was a huge RCT of over 20,000 patients in 40 countries. And they showed that early administration of TXA led to a 1.5% reduced mortality in bleeding trauma patients. Now, that may not be a huge percentage, but with this huge volume of patients, that is really significant. And the number needed to treat is only 67. So there are other trials on the use of TXA and hemorrhage, but this is the one that you should know. And this is the one that changes our practice. So for major hemorrhage, TXA will be given IV. The dose will be 1 gram IV over 10 minutes, then 1 gram over 8 hours. Again, the benefit from the CRASH 2 trial showed that this drug should be given early, so don't wait on it. There have been other trials, I'm not going to talk a lot about this today, but there have been other trials talking about using TXA for brain injury and hemorrhage. And I actually had a patient very recently where a TXA was given for a stable brain bleed. Now, the literature really is not consistent on that, so that is not a use that I'm curious later on we can talk and see if you have any other experience, but that is not an indication I use it for. For the major hemorrhage and trauma, I'm thinking of solid organ injury, penetrating trauma. Those are the things I'm thinking about. But typically in my personal practice, I have not been using it for head bleeds. Epistaxis. This is my favorite use. So that gets number 2, right beyond major hemorrhage and trauma. Because honestly, this is major hemorrhage and it looks like a trauma when these patients are in my ED. So there is some literature to support topical tranexamic acid for epistaxis. And Dr. Gottlieb and friends wrote a nice paper in the Annals of Pharmacotherapy just a few years ago, had 408 patients, and they showed that there was a faster time to discharge and less rebleeding when they used topical TXA in their nosebleeds. And the patient I think about that I really like this on is your patient that comes in, like I had a few nights ago, elderly on Eliquis or Pradaxa. You know that bleed is going to be just a pain to deal with. It's going to be rebleeding. And even with the packing, those ones sometimes just ooze and ooze and ooze posteriorly. So for those patients, I really like to use TXA. Another study that was published actually did a comparison of packing versus topical TXA. Their N was a reasonable size. They had 124 participants. And what I thought was pretty cool is they had a very significant improvement in bleeding at 10 minutes, which is a reasonable time. 73% of the bleeding had stopped in your TXA patients versus only 29% in the packing group. So that kind of goes with my experience. I do a lot of packing, but often there's still some oozing despite that. So the TXA can be fantastic. So here's how you do it. Remember I told you that there's an oral formulation of TXA and then there's an IV formulation. There is not a specific topical formulation. What we're using is the IV stuff. So in my shop, I get a bottle, they'll give me a bottle of TXA and it'll be 1,000 milligrams for 10 mLs. And I'm going to take a cotton pledget. I'm going to unsoak it, or I'm going to unroll it. Then I'm going to soak it. And we put this in the anterior nair. And then I put a clip on. I leave that in place for about 30 minutes. You can go 20 to 30 minutes, but I do 30 minutes. For my experience, I would say that probably maybe 1 in 3 patients can avoid a nasal packing by using this method. So it's not perfect, but I absolutely do feel like I'm able to reduce some packing. A couple questions in here I'm just going to take a look at as we're talking. Let's see. Everyone's wondering about how easy is it to get TXA at your shop? And Dr. Arvanites has it in the department. Dr. Shakel has it in the Pyxis. Dr. Welling looks like they have it in their Pyxis as well. So that's cool. You know, honestly, when I started 7, 8 years ago at my shop, we did not have any TXA. And I don't think it was really a thing locally for epistaxis. And it was only a few years ago that they would start sending it to us from down in the pharmacy. And then starting this year, we've had it right in the ED, which has been kind of awesome. So it's really easy to use. And the biggest trick is giving it time. And of course, like with any other epistaxis management, you need to have the patient, you know, blow their nose, clear the clots before you use it, or it's not going to work. But I found it to be really, really pretty helpful. So post-tonsillectomy hemorrhage. When I asked you what your least favorite of my chief complaints was, a few of you did click post-tonsillectomy bleed, and I agree. Those can be scary. I've only had single digits, probably less than 6 of them in my entire career. But the ones that I've had have been really, some of them have been very, very scary. They, if they're minor, even the minor ones, after you've seen a major bleed, they'll bother you. So 80% of you so far have seen one of these major hemorrhages. Okay. Hello from the kitty cat. All right, that's good. Hey, Sophia, they do want to see the kitty cat, but that's enough kitty time, okay? All right, kitty has to go upstairs. So how do you do it? With minor hemorrhage, Sophia, it is time, okay? You'll use a topical soaked pledget and direct pressure. You can also use nebulized. For major hemorrhage, you'll use IV, and there is a dosing variation, adult versus pediatrics. You can also use topical and nebulized.
Wow,
okay. I've got to send a kitty cat upstairs, guys. Hang tight. You can, going back, now that we don't have a kitty cat with us, going back to the topical, this is the least effective way I have found to stop the bleeding, because most of the time these are kids and they just don't tolerate you pushing this in the back of their mouth. So I would recommend nebulized. I have not yet used IV. I don't know if you all have, but IV for post-tonsillectomy hemorrhage is certainly a possibility. It's something I haven't encountered yet. So gingival oozing. I don't have, with gingival oozing, this is my 90-year-old patient that had a whole variety of dental extractions. And they usually do okay the first day, but then they come to you and they are just bleeding and bleeding and bleeding. So this patient is great for topical tranexamic acid. So let's throw up a poll here. What is your favorite way to stop gingival bleeding dental extractions? And this is a open response. Oops, let's go on. I'll pull it back. There we go. Crush up TXA and apply directly. I don't actually have a pill to do that, but yes, theoretically you can make your own powder of that. What else? Get some other ideas. Bite on a tea bag, yes. Topical thrombin. I have used that as well. So I'll show you what I do with the TXA. So for me, I'll just take, again, the same solution of the TXA, the IV formulation. I'll take 1 4x4, fold it in half, and I'll have the patient bite on it for 15 to 30 minutes. And that seems to help with some of these nasty oozing issues. Now, there is an interesting study that's out right now I think they just finished collecting data, called the Extract NOAC trial. And this is out of, I believe, France. And they are studying a prophylactic rinse of TXA. And their patients are going to be using this prophylactic rinse to try to reduce bleeding after dental extraction when they're on a NOAC. So I'm curious to see how this works. And now that I know that you could do a dental rinse, I'm tempted to consider like making up my own like swish and spit. That might be an interesting thing that we could try. But there's absolutely no data on that yet. When I was reading the study, I thought a swish and spit might be kind of an interesting idea and strategy to have. So the bleeding trach. Here's your scenario. If you have a 50-year-old male on Eliquis, he has a bleeding trach. The trach is obstructed from blood, and you have to replace it. The patient has ongoing slow oozing with distress and desaturation requiring frequent suction. Here's your patient. So, what do you do next? And this is a scenario I faced. It is not a pleasant one. And things happen really, really fast. So what do you do next? This bleeding trach patient. Now, either I really stumped you on this one or pull everywhere's freezing on us. So again, here's our case. A patient is on Eliquis, the bleeding trach. It's obstructed. You have to replace it. They're still oozing and having trouble breathing. They're desatting. You need to suction them a lot. All right, someone's seen my next slide. Nebulized TXA. We're going to talk about that. Any other suggestions? What else can we do? My nightmare. Yeah, it was my nightmare too. This is also where I brought in the cavalry. I had a lot of help in this case because it was not pretty. So let me show you a little bit again about nebulized TXA. So again, I mentioned it briefly during the kitty bomb and the 5-year-old bomb here. But when I ordered this, my RT initially wouldn't do it because they had never heard of it, and it was a new tech in my department. So I actually they had to look it up with me before they were willing to give the medication. But basically, all you need to do if they're an adult size is take 500 milligrams of your TXA, dilute it out in 20 mLs normal saline, and nebulize it. And we nebulized it right through the trach. And honestly, within 5 or 10 minutes, this trach that had been oozing and making my patient cough and desat, it finally stopped bleeding. You could also discuss whether or not we should have reversed the Eliquis. And in this situation, it wasn't going to, we were hoping not to do that. I'll just leave it there. So the oozing finger. Now, this was no one's worst nightmare when I ran the poll a few minutes ago, but I can tell you that oozing fingers just can be a pain sometimes. You know, these are bread and butter cases. Patient came in, they sliced off the fingertip just a little bit. There's nothing to suture, but it just won't stop bleeding. Now, I have all kinds of different things I use, like topical thrombin, and that's certainly a possibility. But think of topical TXA as well as a simple option. So if you didn't think you were in the twilight zone with me already today, now is when we are going to go there for real. The last few indications I want to talk about are things that I have not yet used personally, but are absolutely written about and discussed in the literature and on the forums like EM Docs. We're going to go and talk about some indications that I have not used personally, but are absolutely appropriate or ones worth considering. So the oozing dialysis fistula. Now, this is not going to work for the blood bath. That's just not going to work. But you might consider topical TXA for that one where you have the puncture at the fistula site and it's oozing, oozing, oozing. You'd prefer to obviously not to be putting sutures in if you can. So consider some topical TXA instead. A major indication is postpartum hemorrhage. And I just haven't had a case yet significant enough to give TXA, but absolutely one you should consider in the ED if you have that bleeding patient come in postpartum. So the woman trial, that's the biggie from 2017, had over 20,000 participants again, had a few limitations if you want to read it. For example, they did change their primary endpoint mid-study. They had pretty valid reasons to do it, but it's just worth noting as a bit of a limitation of the structure. And they did show that death due to bleeding, maternal mortality was reduced in the TXA arm. However, the number needed to treat was a bit higher at 250. But given the relative safety profile of the medication, even with this, I would use it. If I had a postpartum patient hemorrhaging, I would absolutely give 1 gram of IV TXA over 10 minutes. Now, in the trial, they repeated the dose times 1 if rebleeding occurred after 30 minutes and was still within 24 hours. Whenever you're using TXA for major hemorrhage, administer it early. The benefits of all the studies have been shown earlier is better. Also written about is major GI hemorrhage. There are a variety of papers. There's a Cochrane review here I'm showing you where they've evaluated TXA in major upper GI bleeding primarily. This Cochrane review did have a whole variety of trials in it. They were all different. The route of the way they gave the TXA was different. The dose was way different. They were giving some really big doses, like 4 grams in some of these studies. So it's kind of hard to generalize the information. There showed a possible mortality benefit in critical patients. But I feel like there's a lot more we need to learn still in the literature about this. So again, if there are no contraindications and the benefit outweighs the risk, in a massive upper GI bleed, I would also consider TXA. Again, you don't have a lot to lose with this medication, but the literature is not as robust for acute upper GI bleed. The last indication on my top 10 I want to share with you today is angioedema. And this one actually was completely unknown to me until I was on the EM Docs for Facebook page or EM forum, and they were talking about using it a few months ago. So I thought that I would read about it. There is a paper out of France looking at TXA as first-line emergency treatment for angioedema that's bradykinin mediated. This was a retrospective chart review, so not as robust as an RCT, and the N was about 33. The results were pretty impressive, though. Of these patients, 27 improved with TXA alone. So, I mean, that's a pretty significant number. Here's another paper. This is out of allergy literature, and they were talking more about it really for prophylactic treatment and reducing episodes of angioedema. And you can see there was a variety of results, but in general, the TXA seemed to help. This was oral TXA they were getting. Then I noticed that in our favorite Tintinelli, there actually was an update just a few months ago where they're talking about having us consider TXA for ACE-induced angioedema or idiopathic angioedema. So I have not yet tried this, but I'm kind of curious about it. And given the right patient, you know, an angioedema patient is quite honestly terrifying. And if I had a new medication to try, I think I would. So I have a question for you all, because this is relatively new to me. Have you used TXA yet for angioedema? And if so, has it worked? We'll do our own mini study here. So someone has used it and it has worked for them. I'm going to know haven't tried it. So we do have very low numbers in our study that we're doing here, but so far no one said that they've used it and it didn't work. But it looks like only maybe 1 or 2 people have tried it and it worked for them. So think about it. I'm going to be really curious to follow more studies on this because, again, with angioedema, I would take anything to help these patients because they are tough cases. Awesome. Thanks for voting, everyone. So we've done a really quick tour through my top 10 tips and tricks for TXA, from using it for major traumatic hemorrhage all the way down to angioedema. I've shown you the common ones and took you into the twilight zone for some of the uncommon uses. You met my daughter and you met my kitty cat. I hope you enjoyed both. So with that, I am going to move on and stop screen sharing for any questions. Looks like Dr. Shakel used it for angioedema recently. The TXA, that's awesome. Dr. Shakal, if you're there and if you're able to unmute, I'm curious, would you be willing to share like the general situation and how long it took for the TXA to give you an improvement?
Yeah, this is, yeah, I'll come off of onto video, I think, but we ended up having a patient who was on ACE inhibitor, kind of a typical story, had a lot of oral pharyngeal swelling, not quite enough to need aggressive airway management, but definitely going to be admitted to the hospital. And we had tried kind of the usual things that we know don't work, and surprisingly enough, they didn't work. Had her admitted to, I believe, our either ICU or step-down unit. And then one of my colleagues actually said, I was just reading something about trying TXA, and I figured, why not? It's worth a shot. And by the time she got up to ICU, they were like, why does she need to be here? It was within about an hour, she was much better and improved and was able to go home the next day.
Thanks for sharing. Any other comments or questions? I've really enjoyed finding all the different uses for TXA. It's such a cheap drug. It's easy to get now and didn't used to be, but I've enjoyed trying to find all the different things I can do with it. I'm always up for new ideas if you have anything I can use it for. I don't think it works on cats.
All right. Thank you, Dr. Mead. So next, we're excited to be able to include a Vapotherm Product Showcase, no mask, no problem, a mask-free, non-invasive ventilation. As a part of our CME, we want to thank them for coming today and allowing us to provide the CME free of cost. You did receive an email that should have had some attached product information. If you want, take a peek at that, or if you haven't, take a peek at it. And then we're going to turn it over to Vapotherm to introduce the speaker. All right, Dr. Simcoe.
Hi guys, can everyone hear me?
Mm-hmm.
Sorry, just getting things set up here. So thanks for having us today. I can start, I'll give you a little bit of an introduction here. My name is Ross Simcoe. I'm an emergency physician at Our Lady of Lourdes Hospital in Camden, New Jersey. And I also work at a critical access hospital in North Central Pennsylvania, 8-bed ER. I've been with Vapotherm, I think this is about the third year I've been speaking for them, but have been using their product for much longer than that. So today we're going to go over no mask, no problem, masks free, non-invasive ventilation with Vapotherm. And before we get started, I'll just go over a disclosure here that I am a paid consultant of Vapotherm. So Vapotherm's high velocity therapy is a tool for treating respiratory distress. The following slides convey study results in relationship to the use of high velocity therapy, but individual results may vary. Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of myself, the speaker. Practitioners should refer to the full indications of use and operating instructions of any products referenced before use. So we'll start off with a case study. This is a COPD patient that a lot of us are probably pretty familiar with. I worked overnight last night, so I know I saw, I think, two patients that were pretty similar to this. So a 60-year-old patient with a history of COPD comes into your ER. They have a history of being intubated within the last month at their last COPD exacerbation. Initial assessment notes some tachypnea, nasal flaring, pursed lip breathing, bilateral wheezing, and a wet cough. So this is a pretty typical, relatively sick COPD exacerbation that comes in your door. We see an ABG that's drawn there below and some vital signs. So we see tachycardia, tachypnea, some hypercapnia, and some respiratory acidosis. Shortly after that ABG was drawn, the patient was started on high velocity. It looks like 25 liters and 60% FiO2. As you can see the timeline going there down the left-hand side, pretty quickly the patient's vital signs kind of started to improve. The tachypnea and tachycardia resolved, and within about 45 minutes, we see a normalization of the pH, and the patient is no longer hypercapnic. So, well, this is not my case. This is certainly like several cases that I've seen myself in the ER, and I think most of us see pretty regularly.
Hey, Ross.
Yes.
Can you share your screen so we can see the slides, please?
Oh, I'm sorry. Give me 1 second.
You should be able to see it from like the green button at the bottom of the screen. It says share screen.
I see the share screen. Give me 1 second to security privacy.
Dr. Simcoe, this is Doug Arnold. If you're not able to get it to go, I can try to share it from my end as well and just control the slideshow.
That would be fine. I'm having some trouble. For some reason, my computer's not letting the securities.
Let me go ahead and try it from my end, and then I'll just control it from my end if we need to do that.
That works for me.
All right, can everybody now see my screen?
Yeah, we can see your screen.
Yes, we can.
Great. Okay, Dr. Simcoe, just if you want to let me know when to move forward, that'd be great.
Sure. Let me. Sorry, let me just get back so I have it up on my screen as well. I'm sorry about the delay, guys. All right, you can go ahead to the next screen, Doug. So some of the things we'll be going over today, the learning objectives that I want to cover. We want to review some of the data and the new literature that's out there demonstrating that high velocity therapy is non-inferior to your non-invasive positive pressure ventilation for patients in undifferentiated respiratory distress. We want to describe some of the mechanisms of action of this therapy. We want to describe and understand the FDA product category designation for high velocity therapy, and kind of how that differs from your standard or historical high flow devices. And we want to understand the applications and potential impact of use in the emergency department. So why does it matter if non-invasive ventilation is mask-free or not? So just looking at some of the literature that's out there, we've seen that about a third of patients based on BiPAP or CPAP have had a failure of that therapy due to mask intolerance, whether that's due to agitation, whether that's due to poor mask fit. But for some reason, one reason or another, 1/3 of patients are not able to tolerate the mask. So what does that mean historically when you have a patient in respiratory distress that needs that had needed BiPAP? Is that you're going to have to elevate that level of care in their acuity, meaning that they're going to probably get intubated, get sedated, go to the ICU, have a longer hospital stay. The other thing that we see is that patients and family, most of them would prefer the interface of a high velocity nasal insufflation and nasal cannula as opposed to a full face mask or even some of the nasal CPAP devices. And then there's the clinician frustration. So some of the time that we spend or respiratory spends trying to fit the mask, or time that we try to convince the patient that they need to leave this mask on or they're going to end up getting intubated. I think we've all been there, trying to explain to our patients that without a therapy like BiPAP or now high velocity nasal insufflation, that they're probably going to go on to intubation. All right, so now to go over some of the clinical data. High velocity therapy is non-inferior to non-invasive positive pressure ventilation for managing undifferentiated respiratory distress. This was a study that was in the Annals of Emergency Medicine 2018, randomized control trial with Dr. Doshi. There were about 218 patients, I believe, that ended up being in the study after randomization and exclusion. The hypothesis was that high velocity nasal insufflation is non-inferior to BiPAP or CPAP in the treatment of undifferentiated respiratory failure. And this was the first randomized control trial of high velocity therapy to include undifferentiated respiratory failure, including hypercapnia. So all the other studies in the past that had been done on high velocity or high flow devices had excluded hypercapnic patients. They had you were basically only in the study if it was hypoxic respiratory failure. So this was the first case or first study to take all comers. And the primary outcome, what we saw is that high velocity nasal insufflation was non-inferior to BiPAP for failure to intubation. And what we also saw is it was non-inferior for all-cause arm failure. So what that means is that in the study, it was considered a failure if you, one, got intubated, or two, you could have a crossover. So if you failed high velocity, you could be switched over to BiPAP. If you failed BiPAP, you could be switched over to high velocity. If we look at some of the secondary outcomes of the ventilatory effects, we see no significant difference between the two in heart rate, respiratory rate, SpO2, PCO2, or Borg scores. And as you see in the graph there, although the PCO2 differed slightly, they follow pretty much exactly the same trend line, whether it was positive pressure or high velocity nasal insufflation. They both look to be equally effective at removing CO2 on these patients. And then we look at some of the discharge diagnoses and what type of patients actually got enrolled in this study. And as we can see, about a quarter of them had a diagnosis of acute COPD exacerbation. Almost a quarter of them had a diagnosis of acute decompensated heart failure. And then we have about 15% pneumonia, and then kind of some asthma and a mixed bag of other diagnoses there. So these graphs are looking at how providers rated the high velocity therapy. And as you can see in the patient response, high velocity was rated higher. Patient comfort, again, high velocity was rated higher, and simplicity of use high velocity was rated higher. So as you can see, it seemed that both providers and patients felt more comfortable and the ease of use with high velocity nasal insufflation was better than that with BiPAP. And then we're going to take a look at a couple of the subgroups in this study. First, we'll look at the acute decompensated heart failure, high velocity nasal insufflation versus BiPAP in the treatment of acute or decompensated heart failure. This is from the same trial, just separating out patients with this diagnosis. And what we can see, if we look at the respiratory rate and the Borg scores, again, we see pretty much the same exact trends over time. We see it didn't matter on the therapy, whether it was high velocity nasal insufflation or BiPAP, that the trends in respiratory rate and Borg score were essentially similar or the same. Unfortunately, these groups did not have enough patients to reach statistical significance, but we do see some trends here that are important, and we'll probably have some further studies with larger populations to kind of help maybe validate some of these thoughts. Now looking at the COPD subgroup analysis, same thing, they just separated out the patients that were diagnosed with COPD, and they wanted to take a look if there was any difference between the two therapies again. And we see here that the PCO2 levels trended down similarly over time. And this was one of the big things, not necessarily for me, since I had been using this for COPD and hypercapnia for many years, but a lot of my colleagues, especially on the inpatient side, when I'm going to admit these patients, would really insist that the patient needed to be on non-invasive positive pressure. They wanted the patient on BiPAP, and for a little while it took some convincing to let me just leave them on Vapotherm, and I told them I would watch them, and if they needed to be converted to a different therapy, I would do that. And what I'm seeing is very few of these patients am I switching over to BiPAP or end up going on to intubation. And now I really get no pushback from any of my inpatient colleagues, whether it's the hospitalist ICU team, for sending people up, sending COPD patients up on Vapotherm. This is just another analysis of the pH levels, again, kind of trended similarly in the same direction over time. And then we look at secondary outcomes here. Secondary outcomes were actually intubation rate. You see that there was a bit of a higher intubation rate with BiPAP, but again, this did not reach statistical significance. And this is just looking at the crossover as well, pretty similar numbers here, failure for intubation and failure for crossover. Very similar numbers there, a little bit higher in the BiPAP group, but again, does not meet statistical significance due to the kind of low population in that subgroup analysis. So what the primary finding was for this was that HVNI is able to provide ventilatory support that is of comparable efficiency to non-invasive positive pressure ventilation in the setting of acute hypercapnic respiratory failure. That was kind of what the authors kind of concluded at the end of the study. Now we're going to switch over and just get a little look at the background of how this therapy works, the mechanism of action. So what this is really doing, what high velocity nasal insufflation doing, is it's decreasing CO2 and washing out the functional dead space. So the end expiratory purge, it decreases rebreathed CO2 with each breath, and it functionally decreases the upper respiratory anatomical dead space. as we know in adults, probably about 1/3 of each breath is being rebreathed, which is anatomical dead space, and in kids, neonates, that's probably closer to 50%. And now if we look at this graph of the kind of volume versus flow, which is important when we start talking about high flow devices versus high velocity devices, there is a big difference. With Vapotherm, it is both high flow and high velocity. There's a small bore nasal cannula, and what that allows us to do is create a higher velocity with the same amount of flow. So as you can see here in the blue, that's a small bore nasal cannula that you would see with Vapotherm products. And then you would see in the orange is a large bore nasal cannula that you see with high flow devices. And you see that at the same volumetric flow, you're getting much higher velocities with Vapotherm or a high velocity technology. These are some models that have been done to demonstrate the difference between high velocity and high flow. Again, the large bore on the right of the screen and the small bore nasal cannula on the left of the screen. You can see travel time down there at the bottom, and what we're seeing with the small bore nasal cannula, the high velocity devices, you're seeing that there's complete washout of that nasopharynx. It's a model of the nasopharynx in about a second. But if we look at the large bore washout, you're seeing there's kind of mixed in there some of your green and yellow, a little bit of red. So washout is not occurring until 2 to 3 seconds. And that may not seem important. You know, what's the difference between 1 second, 2 seconds? But if we look here at the next slide, about flush time, it's really very important, especially when you look at some of our patients that we're seeing in the emergency department that are having respiratory rates of 30, 40, 50, you know, kids sometimes 60, 70, 80 times a minute. You don't have more than a half a second or a second to obtain washout. So that becomes really important. So we can see here we get 70% washout versus for high velocity nasal insufflation versus 20% washout for high flow nasal insufflation, with respiratory rates up in the 60s. 80 to 90% washout versus 40 to 60% washout when we're getting down into the 30s and 40s. And then high velocity and high flow kind of start to even out as you get down to respiratory rates of 18 to 20, but we're still seeing a little bit better washout with high velocity nasal insufflation. So our patients that are you know, most acutely ill and are very tachypnic, it's a big difference in that velocity and being able to kind of fully flush their anatomical dead space and wash out the rebreathed CO2. If we look at the mechanistic difference between high velocity therapy and BiPAP, what we see is traditionally with BiPAP, you're thinking of minute ventilation, which is tidal volume times respiratory rate. That's kind of the basic medical school lecture definitions that we're used to. And then with Vapotherm or high velocity technology, we're looking at alveolar ventilation. And I basically can think of that as minute ventilation corrected for dead space. So you eliminate the dead space, which makes the work of breathing, it allows the same minute ventilation with a decreased work of breathing. If we look at the next slide here, we look at something that's pretty important, maintaining humidity to the patient. We can see some of the competitors' products with heated wire tubing with some fallout or rain out as the device is reaching the patient. And then if we see the high velocity nasal insufflation, we see that the tubing is kind of maintaining, or the tubing, which also means your respiratory gases that being delivered to the patient, is maintaining that optimal optimal temperature all the way to the patient. And that's important because what we know about this is if you're not providing warm humidified gases to your patients, you're probably going to be doing them pretty significant harm and doing some damage to their mucociliary response and maybe even killing some of their mucosa and their cilia if you're using it for any extended period of time. So now if we kind of go on and look and see kind of what the FDA has to say about this, and what the FDA has done here recently has given high velocity nasal insufflation, has given Vapotherm a unique designation, and it's the only device that's in this category that the indication is for augmenting the breathing of patients with respiratory distress as an alternative to non-invasive ventilation products. If we look at the comparison between your high velocity systems, your F&P Airvo, which is one of your high flow devices that's pretty common out there, and your BiPAP device, your Philips Respironics V60 BiPAP device, and you look at the designations that the FDA has given them, what you'll see is that the designation for Vapotherm is very similar to the designation that's given to BiPAP, whereas the other high flow devices are just really for the delivery of warm humidified respiratory gases. So what that's telling me is that we can use Vapotherm on these higher level acuity patients that we historically had thought or had reserved non-invasive positive pressure ventilation for. Now, if we look at kind of the continuum of care, the graph here of invasiveness to clinical acuity, what we're seeing is invasiveness there along the bottom, of course, just starting out with some nasal cannula, oxygen, and then we have our Vapotherm, and then the more invasive would be your positive pressure and ultimately mechanical ventilation. And what you're seeing is high velocity overlaps a lot of different products. It come, kind of right after your nasal cannula oxygen and all the way up to mechanical ventilation. And I think that this is important to talk about, and I like this slide, but I think it's actually a little bit inaccurate because I think there's a large population of patients that Vapotherm can be used on that positive pressure ventilation, these patients are actually excluded. And if we think about some of these things, we think about patients with an altered level of consciousness. You're not really supposed to put those people on positive pressure. Trauma patients, you're not really going to be able to put them on positive pressure. And I'll just give a couple anecdotes of cases that I've had in the last couple of years. One of them was about 60-year-old female who was a syncope, happened to be on Eliquis, fell and hit her head and was altered. Also had a history of COPD. As the ER doc, the history seemed like this was a 100% a COPD exacerbation, and that was likely the cause of her syncope. But as many of you know that work in trauma centers, once you go down the trauma pathway, sometimes you get stuck and you can't get out of it. I was lucky enough to have a trauma surgeon that was able to work with me because the patient, of course, was put in a C-collar. So we're not going to be able to put BiPAP on this patient. So historically, this patient would have just got intubated before they went over to the CT scanner. He allowed me to put Vapotherm on the patient, took the patient over, got their trauma scans, had no acute traumatic injuries, but was found to be very hypercapnic and got admitted to the hospital with syncope and COPD exacerbation and did very well and never required an ICU level of care. Another anecdote that I've used this on many times is substance abuse or overdose. As long as the patient is spontaneously breathing, I've used Vapotherm on many of these folks, as well as hepatic encephalopathy. Some of these patients, there's no way they would tolerate a BiPAP mask, have done very well on Vapotherm and have allowed me to kind of do some things to temporize and to improve other things, like maybe doing a paracentesis on the patient that's in hepatic encephalopathy to actually decrease their work of breathing. So I think that's one thing to consider, is the large population of patients that you can use Vapotherm on that you can't use BiPAP on and historically have been intubated. So clinical application in the emergency department, what we're looking at here, frontline support. This can be used anywhere mild to moderate acute respiratory support, reduces the need for intubation. It also helps sometimes with things like with working with thickened secretions for your COPD patients, your patients with chronic respiratory conditions. It decreases hypercapnia. It also works on hypoxemia. And it helps control all of these symptoms. It takes away a patient's air hunger. So these are all reasons to use this in your ER. So now we're going to talk a little bit about COVID-19 for patients. The initial guidelines recommended intubation as the first line therapy. And I think I had a week or two where I intubated probably a half dozen patients right off the bat. And then we kind of got a little bit smarter and learned from the mistakes of ourselves and some of the other areas of the country that were hit a little bit harder than us, and realized that this was not good for our patients. And what we started to see after that is that most of the groups, the World Health Organization, the CDC, the Society of Critical Care Medicine, and many others, we're suggesting that Vapotherm should be your go-to therapy for these patients. And this certainly was the case in my shop. If you were requiring anything more than nasal cannula oxygen, you got put on Vapotherm, and we would do self-proning in the ER, and we had a lot of patients do really well with this and kept them off the vent. And then we're going to talk about not only how this is going to help your patients from the therapy that's going to or support them from a respiratory standpoint, but also keep your employees safe, healthcare providers safe, as we talk about the risk of transmission with things like intubation, extubation, and suctioning of these patients are very high risk events when we're talking about COVID. We also have to think about the resource utilization and a limited number of ventilators, a limited number of ICU beds, a limited number of staff that are trained for critical care. So if we're looking at the transmission risk, is there any increased spread with Vapotherm during aerosolite generating procedures? And this was something that was pretty huge with a lot of my staff when this first started, is people were really worried about getting infected, whether it was with intubation or whether it was even with Vapotherm. And if we look at the graph here, looking at intubation and the odds ratios here for tracheal intubation and then suction before intubation, we're seeing odds ratios of about 6.5 and 3.5 for transmission. And then manual ventilation before intubation, almost 3. And now if we look at the high flow oxygen, the odds ratio, risk of transmission is down at 0.4. So this is a therapy that's going to help your patients, but also help keep other folks safe. And then as we're looking at some precautions with high velocity therapy, the Chinese Thoracic Society started this by calling for a simple surgical mask over the face of the patient, covering the mouth and nose with a high flow velocity nasal cannula in place. And as we look at some of these models, some of the pictures from the studies that looked at this, that looked at transmission risk, we can see that with no therapy, no mask, the amount of particles that are being dispersed. And then if we look with just wearing a mask and then wearing a mask with high velocity nasal insufflation at 40 liters per minute, what we're seeing is actually more particles are captured with high velocity nasal insufflation at almost 90% than when people are just wearing a mask and breathing regularly. So the thought that this may be that the exiting gas coming out of the nasopharynx is at a higher velocity, that it's getting blown straight into the mask and doesn't have time to leak out around the sides, or the top or the bottom. But as you can see, it looks like the risk is actually decreased with a mask. So the conclusion to this is that if we can just use a well-fitting surgical mask over the high velocity cannulas, should reduce the spread of particles. The surgical mask application does not eliminate the clinical efficacy of high velocity therapy. There's also one other option, if you're lucky enough to have this at your institution, is the negative pressure scavenger kit. Unfortunately, we don't have these at anywhere that I work, but the Felix 1, as you can see, demonstrated being used on a patient. And in these modeling studies, what we saw with the surgical mask being around 90% of particles capture, what we see with the Felix 1 only, that goes all the way up to 97%. So if you're lucky enough to have these, you can feel really very comfortable about having a patient with COVID on Vapotherm. So now looking at the implementation of high velocity therapy in the ER. So there's been an increase in acute respiratory failure as a diagnosis. Hospitalizations have doubled in the last 9 years. It's the most frequent cause for ICU admissions, and 30% in hospital mortality for these patients requiring intubation. And so looking at keys for utilization of high velocity on these patients, or high velocity nasal insufflation on these patients that are coming in, is that we need to use supraphysiologic flows. So most of the time I'm starting this at 35 to 40 liters on my adults. And that flow rate is key to achieving ventilatory support. There also needs to be the correct patient interface. So it needs to maintain an open system, meaning that you can't occlude more than 50% of the nair. And for neonates, they actually have a uniprong nasal cannula as well, if that becomes an issue, if they have feeding tubes in. So as we see here, to titrate, we're starting at 25 to 30 liters per minute in adults. I often start at 40 if they're sick. And with pediatrics, you're starting at 1.5 to 2 liters per minute per kilo. And then the FiO2 is independent of the flow. So you can titrate that anywhere from room air for 21% up to 100%. And then obviously maintaining that at an optimal temperature range to increase comfort, and also get the benefit of secretion mobilization. So the scope of this high velocity therapy is it provides oxygen support and non-invasive ventilatory support. We're seeing a lot of hypoxic respiratory failure patients, especially in COVID-19. The prevalence is almost 20%. It can help with hypercapnic patients and hypoxemic patients, and it can help them avoid endotracheal intubation. It does provide a small amount of PEEP, probably 3 to 5, in the range of 3 to 5, which may help with ARDS. And the warm humidified gas helps improve conductance and pulmonary compliance. So in summary, the clinical evidence is out there that suggests that high velocity nasal insufflation is a viable alternative to BiPAP in really all comers in respiratory distress. And that high velocity therapy is not a traditional commodity high flow oxygen system, and it's not CPAP. And that the FDA has identified that Vapotherm has a unique product and has designated it as such. and this high velocity therapy, the mask-free non-invasive ventilation with clinical applications in the ER is going to help you decrease intubations, keep people out of your ICU, and hopefully help manage the flow of your department. So thank you guys. I apologize for the technical difficulties there, but I'll see if we have any questions here. You guys are also welcome to contact me at the email address there. I'm happy to take any questions at any time. But I mean, if you guys have any questions, you can feel free to type them into the chat box.
Dr. Simcoe, that was awesome.
Just a reminder, if you do have any questions, to come off of mute to ask questions of Dr. Simcoe. And as he mentioned, you can reach out to him directly via email as well. I didn't get a chance to introduce myself at the beginning. I apologize. It looks like you started a little bit earlier, but this is Doug Arnold. I'm the Executive Account Manager in Michigan with Vapotherm. Also on the call is our clinical manager, Kenyetta Stanley, who is a registered respiratory therapist who provides all of the education and clinical support to our customers throughout the state of Michigan. And then also our regional business director, Mia Jacob, who's based out of Chicago, who's responsible for the Midwest with Vapotherm. So apologize we didn't get a chance to introduce ourselves at the beginning, but we do appreciate this opportunity to present to the Michigan ACEP and appreciate Dr. Simcoe's time to discuss Vapotherm with all of you. And if you do have questions, looks like a couple are coming up here in the chat box now, but just make sure you come off of mute if you have any questions you want to vocalize to Dr. Simcoe.
Doug, it looks like someone's asked about any EDs in Michigan using Vapotherm. I don't know the answer to that question, but I don't know if you guys could help out with that at all.
Yep, absolutely. Vapotherm is used throughout the state of Michigan. Just about every major hospital healthcare IDN within Michigan is utilizing Vapotherm and utilizing, not only in multiple care areas throughout the hospital, but in the ED as well. If you need specific references, I can be reached. I'll kind of say my email out loud here. In fact, I'll put it in the chat box as well. It's darnold@vtherm.com. So if you have any specific questions or you need to reach out to me regarding references that you'd like to talk to, or having me come in and discuss Vapotherm with your staff and yourself, I'm more than happy to set up those types of meetings. And we've fully embraced this virtual scenario that we're currently living in with COVID. And we're more than happy to set up virtual meetings and discussions as well, if that's how your facility would like to handle these types of discussions.
Just looking at some of the other questions that have popped up, we have a question: how do you decide if a patient can go on Vapotherm or needs BiPAP? In my shop, we put almost everyone on Vapotherm. We've become a very heavy Vapotherm shop, and that's because we've seen the results, and we've been doing that for years. I think that's a tough question as far as who needs what. A lot of this becomes like what therapy you're comfortable with. And what I see is that once docs get Vapotherm in their ER and start putting it on patients, and they see how easy it is to use and see how well their patients like it over having a larger mask on, and see them doing well, then they usually opt for to go more with the Vapotherm. Pretty much the only populations that I'm not putting Vapotherm on is if our EMS crews are bringing folks in already on positive pressure and they're doing well, then I don't switch them off. I just maintain that therapy. And then just looking here, It looks like a question about the spread of infection. So compared to BiPAP, BiPAP is, and sorry, I don't have the studies right in front of me with the exact numbers. There was actually some really good studies put out on this year. BiPAP is other than direct endotracheal intubation, BiPAP is the highest risk for spread, I do believe. Nasal cannula, the spread is actually, nasal cannula in a mask is actually a higher risk than Vapotherm. And again, I believe that's due to the high velocity which you were getting, that those particles come out and go directly into the surgical mask, and there's no leakage around the mask. And I believe that the non-rebreather, since that is essentially a mask in itself, I believe that was the safest option in the literature that some of these organizations like the CDC and critical care groups put out. But I can get, if anyone wants that, if they email me, I can get you guys, there's some really good studies and literature out there on that. Pediatric patients, how did pediatric patients tolerate Vapotherm? I have had no issues in pediatric patients or adult patients for that matter. I don't think I've ever had a single patient demand that I take off this therapy. Some of them have asked me to decrease flow rates, but they've always tolerated the therapy and left the cannula in. And RSVCs and Vapotherm is one of my go-tos. If you can kind of get the patient, the littler kids calm down, have the parents hold them, and get them. Oh, sorry, someone cut in there. I didn't hear that question, but.
I think they just unmuted themselves on accident.
Okay. But pediatric patients, adult patients all seem to tolerate this very well. I haven't had any issues with that. I mean, of course, your sick kids are going to be fussy, but no more fussy than a regular nasal cannula. And then Dave, let's see what Dave Benton has to say. Yeah, Dave, I not really a question, but I agree with 100% on what you're saying, that we need to talk with nursing and respiratory and educate our residents and our colleagues to kind of avoid intubation in some of these patients and use alternative therapies. There were I'm guilty. The first couple of weeks I intubated probably at least a half dozen people that probably didn't need intubated. And since then, I've only intubated one, and we were seeing a lot of COVID for a couple months here in Camden, New Jersey. So I agree 100% with that, Dave. All right, guys, if there's no further questions, it looks like it's almost 1 o'clock. I thank you guys all very much for your time and having us from Vapotherm here to talk with you. And again, we're all very open. Reach out to us by email, whatever's easy for you. We're happy to talk, or if you have questions or want to see a unit or get it in your shop, go ahead and let us know.
Dr. Simcoe, thank you so much for coming. We appreciate the talk. It was really, really interesting to hear. I know I've tried it once at one of our conferences. They came and demoed it, and I would love to see it in Saginaw. I think it's a great tool to add. So thank you so much for visiting, taking your time from New Jersey to visit us today. Thank you to Doug and everyone else from Vapotherm that also joined us for the last hour of the conference. So with that, it is time to wrap up. I want to thank everyone once again for joining us for the morning. I hope you learned something. I hope you enjoyed meeting kitty cats, and it's been awesome to have you all here today, over 50 to 60 at a time. And we hope you can join us on September 30th for our last session. And we'll have a whole list of great speakers, variety of topics. We've mixed up the topics each time, so I think you will thoroughly enjoy them. And don't forget to also fill out your evaluation for CME. If by some chance you did not have your name on the participant list, you're logging in from iPhone, please go ahead and make sure you email Maddie Her email address is on our website, mcep.org, and we will make sure you get your CME. But keep an eye out for the evaluation and CME forms so that you can get credit for coming today. Have a great day. It's beautiful weather outside. I just checked, and we look forward to seeing you next time. Thank you, everyone.